முடிச்சதுக்கு அப்புறம் we'll go for investigations.
Okay, sir. Every case வந்து for half an hour it can be discussed. Total half an hour.
ஆமா, Rahim come up and guide them. Thank you very much. Yes, you can start, Alex.
Good morning, sir. Shall I start, sir?
Yes, please.
Yes,
Go
yes.
ahead.
Good
Once
morning,
the
sir.
chair says so, you can start.
Good morning, sir. Good morning, ma'am. I thank you for the opportunity given me to present in this prestigious forum. I thank my respected teacher, Dr. Sedram sir, our chief, and I thank Dr. Kalpana ma'am for being backbone for this case and guiding me through to arrive the diagnosis and out for this presentation. Thank you, ma'am. We will now move towards the case, diagnostic crossroads, where there are crossroads in the process of diagnosing this case. So, Mrs. Yates, a 40-year-old female, right-handed individual, studied computer science diploma and computer operator by occupation with premorbid status of independent to do all activities. She came with complaints of difficulty in using both lower limb and upper limb for the past 3 years and complaints of paresthesia of upper limb and lower limb for the past 2 years. And coming to history of presenting illness, she was apparently normal 3 years ago, followed by developed history of difficulty in using both lower limb and upper limb for the past 3 years, which was insidious in onset, gradually progressive in nature, in the form of history of aware slippage of slippers, history of difficulty in getting up from squatting posture, history of difficulty in climbing upstairs, history of difficulty in carrying out bucket of water, history of difficulty in hooking jackets for the past 2 years, associated with history of buckling of knees, with history of falls, history of flailiness of limb, history of progression of weakness in the form...
Alex?
Yes, sir.
With no history of falls in போட்டிருக்கீங்க. Nova history of falls.
No history of falls, sir. Sorry, sir.
Right.
No history of falls. History of cramps over thigh muscle and upper limb muscle, with no history of twitching of muscle, no history of thinning of muscle, but however, history of swelling over both calves and both upper limb present. There is no history of diurnal variation of fatigability. She complains of paresthesia for the past 2 years in the form of burning sensation of palms and soles, history of reduced perception of temperature of water while bathing in the distal upper limb and lower limb, history of reduced perception of mosquito bite in the distal upper limb and lower limb compared to other region, history of unaware slippage of slippers, history of increased perception, sensory perception of slight painful stimuli as severe pain when her children pinch and play with her, which was bearable by her previously. Now she complains of severe pain. History of small joint and large joint pain of upper limb and lower limb, dull aching in quality, not associated with movements, relieved with medication. History of early morning stiffness for the past 3 years. History of pain over bilateral ankle and toes for the past 1 week. History of aggravation of weakness and symptoms for the past 1 week, for which the attender and patient came to medical attention. She is able to see clearly without double vision, no history of color vision abnormality, no history of restriction of field of vision, able to move eyes in all directions, no history of drooping of eyelids, able to perceive sensations normally over face, no history of facial asymmetry noted by her family members, no history of giddiness, vertigo, tinnitus, reeling sensation, and hard of hearing. History of able to close eyes completely, able to bite, tear, grind, and chew food. There is no history of dysphagia, dysarthria, nasal tone of voice, or nasal regurgitation. History of able to perceive sensation normally in the perineal region. No history of giddiness, swaying while walking, or excessive stressing of syllables or explosive speech. No history of stiffness of limbs or involuntary posturing. No history of band or girdle-like sensation. No history of foot deformity. No history of recurrent ulcers. No history of bowel and bladder abnormality. No history of associated giddiness or postural syncope. Abnormal sweating or any flushing, palpitation. No history of altered sensorium or behavioral disturbance or memory disturbance. No history of loss of consciousness, seizures or involuntary movements or headache. No history of rash or dryness of mouth or eyes. No history of fever. No history of epistaxis, hemoptysis. No history of toxin exposure and no history of substance abuse. History of loss of weight 2 to 3 kgs over 6 months. She initially had a weight of 67 kgs. After 6 months became 64 kg. And history of loss of appetite and history of hair fall present. History of usage of analgesics over the counter to elevate the pain. Now, coming to past history, patient is a known case of bronchial asthma for the past 10 years and known case of hypothyroidism for the past 5 years on treatment. Personal history, she consumes mixed diet, no substance abuse, normal sleep pattern. Family history, no history of similar illness in her family. History summary, a 40-year-old female with known hypothyroidism and bronchial asthma with background history of multiple joint pain involving the small and large joints of both upper limb and lower limb with history of early morning joint stiffness for the past 3 years, presented with history of difficulty in using both upper limb and lower limb, which was insidious in onset, gradually progressive in nature, initially distal lower limb weakness followed by proximal lower limb weakness. After 2 years, history of distal upper limb weakness followed by proximal upper limb weakness with history of flailiness of both lower limb with no history of fasciculation. History of sensory disturbance for the past 2 years in the form of paresthesia of both lower limb and upper limb with a normal cranial nerve, cerebellum, extrapyramidal, and with normal higher mental function. So structures
Okay.
involved are yes, sir.
Continue.
Continue and tell
Okay,
the investors.
Structures involved are small fiber plus large fiber peripheral nerve, bilateral symmetrical proximal and distal sensory motor polyneuropathy without any autonomic
Alex.
involvement.
Alex,
Yes, sir.
I am Justin, Dr. Justin.
Yes, sir. Good morning, sir.
Good morning. When you are summing up the structures, it is an UMN lesion or LMN lesion. First, you have to say.
Okay,
Then
sir.
you localize what are whether it is a hinder cell, a root, peripheral neuromuscular junction, or a muscle or peripheral nerve. Right?
Okay. Okay,
This
sir.
is how you have to discuss in the exam. This is
Okay,
a basic
sir.
pattern.
Okay, sir.
Rajan sir.
I welcome
sir.
Professor Justin.
Yes, sir.
Yes, sir. Yes, Justin. Yes,
Yes,
Justin.
sir.
We'll
Jawahar, sir.
allow him to present the findings also,
Yes,
and
sir.
then we'll make comments on the presentation as well as on the case, so that will
Yes.
give us more time.
Yes, sir.
So let him go ahead with the presentation of the findings. Then we'll come up with finally with the comments on the presentation itself and
Yes, sir.
also on the case,
Yes, sir.
because we have 4 cases.
Oh, okay, sir.
Yes, sir. Go ahead, Alex. Go ahead with your whatever you want to say, you say, and then go ahead with your findings.
Okay,
We'll
sir.
come back to these questions later.
Okay, sir. Thank you, sir. Differential diagnosis on a background of multiple joint pains and hypothyroidism. Differentials could be vasculitic neuropathy and hypothyroid neuropathy. So, examination, general examination, patient was conscious, oriented to time, place, person, well built and nourished, no pallor, icterus, clubbing, cyanosis, pedal edema, lymphadenopathy, normal oral cavity, tonsil, nails, and no hypo or hyperpigmented lesions, no purpura, no neurocutaneous marker, no goiter, neuropathic tremors are present, no peripheral nerve thickening, vitals, pulse rate 88 per minute, regular, normal volume, all peripheral pulses felt equally, blood pressure 120-80 mm of mercury in supine position, in sitting position 110-77 mm of mercury, respiratory rate 16 per minute, saturation 99% in room air, temperature is afebrile, higher mental function, MMSE 30 out of 30. She is a right-handed individual, studied diploma computer science. Orientation to time, place, person normal. Attention and concentration was normal. Cranial nerve examination. First and second cranial nerves examination normal. Third, fourth, sixth, fifth cranial nerve examination was normal. Cranial nerve 7, 8, 9, 10, 11 cranial nerve examination normal. 12th cranial nerve examination, there is tongue atrophy with the fasciculations. So this picture depicting the first picture depicting the tongue atrophy, and second is a video of tongue fasciculation and atrophy.
Alex, is the tongue atrophy unilateral or bilateral?
Sir, there is bilateral tongue atrophy, sir, with the fasciculation, sir.
So I think left is more wasted
Yes, sir.
Obviously.
than the right.
Shall I go to the next slide, sir?
Yeah, please
Yes, go
continue.
ahead.
Continue.
Okay, sir. Bulk, right arm 23 centimeters, left arm 22 centimeters, right forearm 21 centimeters, left forearm 21 centimeters, thigh right side 44 centimeters, left side 43 centimeters, leg right side 34 centimeters and left side 33 centimeters. There is bilateral calf and brachioradialis hypertrophy and EDP is wasted. So this image shows a bilateral calf hypertrophy.
Is it really a calf hypertrophy, Alex? I don't know. This photograph doesn't seem to have calf hypertrophy when you have, but you have seen the patient directly, so
Yes, sir.
you are convinced, isn't it?
Yes, sir. Yes, sir.
Excuse me, sir.
Hmm.
Excuse me, sir. Sir, this is Dr. Kalpana, sir. Sir,
Yes,
Yes,
many
yes.
go
of
ahead.
them, many of the senior neurologists seeing this photo have told that there is no calf hypertrophy. Still, why do you want to tell us calf hypertrophy? Many have asked me, sir. But clinically, I am convinced that there has been calf hypertrophy, and also patient gives significant history, sir. That கால் வீங்கிருக்கு, she was repeatedly telling it. So we need to take into account, sir.
Hmm.
கால் வீங்கி இருக்கிறது ஃபோக்கல் வீக்கம் சொல்றாங்களா அவங்க அந்த காஃப்ல தான் வீக்கம் இருக்குன்னு சொல்றாங்க.
காஃப்ல தான் வீக்கம் இருக்குன்னு சொல்றாங்க, sir. Again and
Okay,
again we
agreed.
told,
Agreed,
she
agreed.
is
Right,
telling,
right,
sir.
right.
Agreed.
Yes, sir. Okay,
அது
sir.
தவிர
Thanks.
பிரேக்கியோரேடியல்ஸும் சொல்லியிருக்காரு.
That also she was repeatedly telling, sir. So
Yes.
we were not able to ignore it, sir. Whatever
need to
may
ignore.
be,
Ma, no
for
need
your
to
opinion,
ignore.
sir.
No
Okay,
need
sir.
to ignore. It has its own weight. Don't
Okay,
ignore.
sir. Thank
Okay,
you, sir.
sir. So this image shows a bilateral brachioradialis hypertrophy, sir.
Continue, pa.
Yes,
Yes,
sir.
yes.
Tone in the upper limb and lower limb is normal to reduce, sir. Coming to power examination, neck flexion extension power was normal, trunk power was normal, shoulder flexion 4 minus in the right side and 4 on the left side, extension 4 in the right side and left side, abduction was 4 plus in the right side and left side, adduction was 4 in the right side and 4 plus in the left side, elbow flexion 4 in the right side and 4 plus in the left side, extension 4 plus in the right side, 4 in the left side, wrist flexion 4 minus in the both right and upper side, wrist extension 4 in both right side and left side, hand grip was 60% in the right side and left side, and hip abduction was 3 in both sides, adduction flexion extension was 3 in both sides, knee flexion was 4 minus in both sides, knee extension was 3 in both sides, angle dorsiflexion right side 4, left side 4 minus, plantar flexion 4 minus in the right side and 3 in the left side, inversion was 4 minus in both sides, eversion was 4 minus in both sides, EHL power was 3. Patient had restriction of movement due to pain while examination. Superficial reflex examination, corneal, conjunctival, gag, superficial abdominal reflex and plantar was present. Plantar was bilateral flexor.
Alex, where was the pain during
The
examination?
pain mainly in the large joint and both large joint
Okay,
and
joint
small
pain.
joint.
Okay.
Joint
Continue.
pain, sir.
Okay, okay.
Sir. Superficial reflexes, corneal conjunctival reflex present, gag was present, superficial abdominal reflex was absent, plantar was bilateral flexor, sir. Deep tendon reflex, jaw jack was absent, deep facial reflex was absent, other reflexes biceps, triceps, supinator, finger flexor, knee and ankle was absent, sir. Sensory system examination, pain, temperature, touch. There is a graded pattern of sensory loss till thigh in lower limb and till elbow in the upper limb. There is normal vibration in upper limb and lower limb. Spinal vibration was normal. Joint position sense in the upper limb and lower limb was normal. Rhombox was negative. Perineal sensation was normal. Anal tone was normal. There is no spinal tenderness. Extrapyramidal signs was normal. Cerebellum system examination, bilateral finger nose test, finger nose test, heel shin test, able to perform. There is no rebound phenomena, no nystagmus, no dystidagokinesia. Extrapyramidal system, there is no bradykinesia, rigidity, rest tremors, and globular tap was accommodative. Autonomic nervous system examination was done. There is no resting tachycardia, no orthostatic hypotension, no sweating abnormalities. Autonomic function test was done. In skull and spine, no spine tenderness, no gibbous or deformity. There is no signs of laryngeal irritation, and gait was antalgic gait. Other system examination was done, sir. Local examination, patient had bilateral angle joint tenderness. CVS examination, S1, S2 heard, no murmur. Respiratory system, normal vesicular breath sounds was present. Abdomen, soft, non-tender, no organomegaly. Bowel sounds were heard normally. So after examination summary, a 40-year-old female with known hypothyroidism and bronchial asthma developed insidious onset progressive weakness of both lower limb followed by upper limb, lower limb more than upper limb, distal followed by proximal, with history of paresthesia of both lower limb and upper limb, with pre-existing multiple small and large joint pain, with early history of early morning stiffness, and examination EDB wasting, neuropathic tremors with hypertrophy of both brachioradialis and calf muscles, and tongue atrophy with fasciculation, and hypotonia of all four limbs, distal more than proximal weakness of all four limbs, generalized ear reflexia, decreased touch pain temperature till thigh and elbow with normal joint position sense and vibration of upper limb and lower limb. Patient had severe pain of limbs on touch and on moving of the limbs. No evidence of any involvement of bowel, bladder, other cranial nerve, cerebellum, extrapyramidal or higher mental function.
Rombox positive, isn't it?
Sir, Rombox, it was negative, sir.
Negative.
Yes,
Okay.
sir.
Okay.
So our differential diagnosis, taking into tongue atrophy and fasciculation, and associating, we thought it can be transthyretin amyloid neuropathy, and dissociating vasculitic neuropathy or hypothyroid neuropathy, both together muscular myasthenia or ALS, sir.
Now answer
Okay.
Professor Justin's question earlier. You said earlier from the history itself it was vasculitic neuropathy or hypothyroid
Yes,
neuropathy.
yes, sir.
Professor Justin asked, how did you come to the conclusion it was a nerve involvement?
Sir, patient symptoms started first in the distal area, sir, followed by proximal involvement, and it was a progressive symptom, sir. So initially, the longest nerve involvement pattern happened, sir, lower limb. Then second longest upper limb pattern happened, sir. And the patient doesn't have pattern of first proximal involvement followed by distal involvement as per history also, sir. So I consider this patient is having a peripheral nerve as localization, sir.
At the history level, why not a muscle? I don't know. Professor Justin, you can continue with your asking him.
Alex.
Yes, sir.
See, actually, you go back to your this summary of that history. You go back to the slide quickly. Summary of the history. Still.
Yes, sir.
Yes. So in this with this background history, what you told, difficulty in using both lower limbs, upper limbs for the past upper limbs is insidious onset, gradually progressive nature. Initially distal lower limbs, followed by proximal lower limbs, proximal weakness, and then
Yes,
2
sir.
years after distal upper limb weakness, followed by proximal weakness with the plialness.
Yes, sir.
With the history of sensory disturbances in the form of paresthesia. So, what is your inference from this history?
Sir, from
With
this
the joint
history,
pain.
yes, sir. From this history, patient is having an Ellerman syndrome, sir. Since patient is having initial involvement of the distal lower limb muscle motor weakness, followed by patient is having proximal lower limb motor weakness, sir. Then progress to distal upper limb motor weakness and followed by proximal upper limb motor weakness, sir. And gradually patient developed a sensory disturbance, sir.
But don't repeat the findings.
So,
He's
okay,
asking for
you tell
your
me
inference.
what could be the differential diagnosis?
Why did you come to that diagnosis?
Yes, sir.
That's what Justin sir is asking.
Yes, sir. Patient has with the alone motor history, patient is having polyneuropathy, sir. Predominant motor weakness, motor involvement initially, sir, begin with. Then followed by patient developed sensory neuropathy, sir. Initially, patient had a distal lower
Yeah,
limb.
yeah, already said.
So
Okay,
okay, this is
so what?
Yes,
this
sir.
is peripheral neuropathy or any other CIDP or a vasculating neuropathy. What you are
Jawahar,
referring to?
Jawahar, Justin என்ன கேக்குறான்னு தெரிஞ்சுப்போம். Justin கேட்கட்டும்.
Sir,
The patient is having both motor plus sensory involvement, sir, in this patient. So I consider patient is having peripheral now, sir. If it's an anterior Honsel disease, it could be.
No, that is enough. You wait for the question from Justin.
Okay, sir.
You answered that. Wait
Yeah.
till he asks you something more.
yeah, from the history, it is an LML lesion. Agreed. Whether it is an anterior Honsel disease, points favoring. Is there any fasciculation? What's the history level? There is no
At
fasciculation.
the history level, that's no
Yeah,
facility.
that is wasting is more than weakness. It is not so.
Yes, sir.
So I am ruling out anterior Honsel. Then we are root. It is an involvement of the roots. Proximal muscle weakness is there. Agreed. Motor root is involved. It is not an NMJ. There is no diurnal variation. It is not the muscle because it has got a sensory disturbance. It has got an involvement of the peripheral nerve. Yeah, clearly it is length dependent pattern where it's involved the distal, then it goes up to the proximal. With the background of history, at the history level, it has involved the peripheral neuropathy plus roots. So polyradiculoneuropathy. With this background of hypothyroidism with bronchial asthma, 40-year-old female, I will like to think in terms of any immune-mediated polyradiculoneuropathy of chronic etiology, CIDP possibility. See, underlying first multiple joint pains and other things, I would like to think in terms of first is connective tissue disorder. Are we dealing with a connective tissue disorder? One, at the history level.
Yeah, okay, sir.
This is the first, because all are bronchial asthma, hypothyroid, multiple joint pains, everything goes favor for underlying autoimmunity.
Yes, sir.
So possibility is chronic inflammatory demyelinating polyradiculoneuropathy of possibility of underlying autoimmune etiology like collagen vascular disease because 40-year female. Then only you have to go for your examination. Additional findings you have find out is one is tongue fibrillation.
Yes, sir.
And calf muscle hypertrophy as mentioned by Kalpana madam.
Yes, sir. And
Other things, they are more favor for all your radiculoneuropathy only, everything absent reflexes, hypotonia, everything. So how to explain this tongue fibrillation? We can have a CIDP, we can have a, as you mentioned, that amyloidosis can involve the tongue as well. And your immune-mediated neuropathy can involve the 5th nerve as well as the 12th nerve also. Tongue fibrillation have been reported with the CIDP also.
Yes,
So
sir.
possibility is CIDP, probably a immune-mediated etiology.
Yes, sir.
Is there anything to add more, sir?
Jawahar was saying something. Jawahar, சொல்லுங்க.
Okay, this in your differential diagnosis, you put it as a vasculitic neuropathy, isn't it? Vasculitic neuropathy.
Yes, sir.
You go next slide, vasculitic neuropathy and
one more DD was
அடுத்தது hypothyroid
neuropathy. So in a vasculating neuropathy, what type of sensory disturbance will be there most commonly?
Sir, most commonly it will be mononeuropathy, sir. First to begin
So
with,
okay, mononeuritis multiplex.
Followed by patient will develop sensory motor neuropathy, sir.
That is that sensory disturbance is mostly small fiber neuropathy.
Yes,
What
sir.
it happens in a vasculating neuropathy. In this patient,
இந்த பேஷண்ட்க்கு அதான் இருந்தது.
in this patient,
small fiber தான் இருந்தது.
Yes, sir. Small fiber history wise, sir. Initially.
History wise small fiber.
Yes, sir.
Okay, right. So this patient, but the presentation distally, then proximally, and then the lower limbs and the upper limbs, as Dr. Justin told, it could be, we have to think of CIDP in this patient. So your differential diagnosis, you are not included CIDP in this patient. Okay. And second thing, hypothyroid neuropathy, you mentioned. Hypothyroid neuropathy, usually it will present with what are the classical symptoms?
Sir, initially in the hypothyroid neuropathy, there will be a compressive neuropathy, sir.
But usually commonly present with
carpal tunnel syndrome.
That is okay.
Sensory
Entrapment neuropathy is commonly present with the peripheral sensory predominant peripheral neuropathy. Sensory predominant peripheral neuropathy.
Yes, sir.
So in hypothyroid neuropathy, we won't get this much of weakness proximal and distal. Okay.
Okay,
This is history wise. And then examination, after examination, go back to your examination summary. Finally, what is your conclusion? You see, your examination showed upper limb, there is a distal limb weakness more than the proximal in upper limb. But in the case of lower limb, it is proximal weakness slightly more than the distal.
Yes,
And
sir.
with the absent reflexes in the ankle joint, and knee joint also.
Yes, sir.
Knee joint also.
Yes, sir. Patient had severe pain, sir. Probably there could be an algic paresis that could explain, sir, that reduced reflexes and power-wise proximal more weakness. Could that explain, sir?
Okay. Now I want to raise the question. You told the patient has got a restricted movement to the joint pain. Whether this proximal weakness is due to joint pain or real proximal weakness is there at the time of examination.
Sir, at the time of examination, patient had severe pain, sir. Beginning after starting of treatment only, the pain subsided, sir.
Okay. After subsidence of pain, the proximal weakness slightly improved.
No proximal weakness, sir.
No proximal weakness.
Yes, sir.
That is why, in this case, why? Because in the background of rheumatoid arthritis, you told it could be a joint pain, so possibly a rheumatoid arthritis and all. So, what will be the presentation neurological manifestations of rheumatoid arthritis?
Sir, neurological manifestation of rheumatoid arthritis, sir. It can present with the first involvement of mononeuritis pattern called mononeuritis multiplex, sir. Later, it can go for sensory motor neuropathy, and it can be carpal tunnel syndrome, sir, or posterior interosseous nerve palsy.
So,
or
okay.
cubital
So,
tunnel
for
syndrome.
the information that the entrapment neuropathy is most common manifestation of rheumatoid arthritis, like carpal tunnel syndrome, tarsal tunnel syndrome, and all. And then next comes the peripheral sensory predominant peripheral neuropathy. Third is mononeuritis multiplex. And mononeuritis multiplex, that is due to vasculitis. So usually in rheumatoid arthritis, you won't have a proximal weakness. If at all you have a weakness in rheumatoid arthritis, that is due to mononeuritis multiplex, which will affect the peripheral nerves. So the proximal weakness in the case of rheumatoid arthritis, if the patient is having, it is due to joint pain rather than a real muscle weakness.
Yes, sir.
And usually the vasculitis involves the peripheral nerves in rheumatoid arthritis. Okay.
Yes, okay,
So we have to think this proximal weakness may be due to joint pain in this case. Okay, right. So what is your final after examination? What is your final diagnosis?
Sir, after the examination, on associating a tongue atrophy with fasciculation, sir, we can think in terms of transthyretin amyloid neuropathy, sir. And dissociating, it can be tongue atrophy with fasciculation. If dissociating, sir, we can think with the pre-existing rheumatological disease, we have to rule out vasculitic neuropathy, sir. And
Alex,
sir,
amyloid neuropathy ke predominant autonomic nervous system இருக்கணும், pain இருக்கணும்.
yes, sir.
ரெண்டுமே இல்ல. So
sir.
don't bring in amyloid neuropathy.
Yes,
Apart, there are a lot of other faculties, senior members, neurologists are there. They can also join in and give their comments also. Please.
Alex,
Yes,
I am
sir.
Dr. Alagason.
Yes, Alagason, please.
Good afternoon, sir.
Welcome, Alagason, Dr.
You have mentioned about the neuropathic tremor,
Yes, sir.
but you have not mentioned anything about the clinical feature of the tremor. And your clinical findings more in favor of small fiber neuropathy.
Yes, sir.
The small fiber neuropathy, can it give rise to neuropathic tremor? The second point is,
yes, sir.
and in our patient, the fasciculation is largely asymmetrical. Left is more than the right. Tongue atrophy. Atrophy is also more on the left side.
Yes, sir.
So I think maybe due to we all know that rheumatoid arthritis can affect the spine. Maybe adult axis subluxation or the pannus in the spine can cause the 12th nerve palsy.
Yes, sir.
So for that, why do you want to invoke amyloid neuropathy as Professor Natarajan said?
Sir, examination
There is
wise,
no autonomic
there is no
sensory
autonomic involvement, sir. But since there is presence of tongue atrophy and fasciculation, We kept DD. On seeing this, we deceived, sir. On seeing the tongue atropine fasciculation, clinically, we deceived towards we have to rule out transthyretin amyloid neuropathy. But clinically, patient is not having any autonomic involvement, sir.
So that is the basic thing. Without autonomic involvement, you cannot invoke the possibility of amyloidosis.
Yes, sir.
So in this case, the tongue fasciculation may be due to unknown cause, which we are not sure at this
Yes, sir.
moment. What is the cause?
Yes, sir.
Sir, excuse me,
Okay.
sir.
Mm.
Sir, excuse me, sir. Can I have one
Please,
more
please,
Yes,
point?
Kalpana,
yes.
please go ahead.
It was not our diagnosis. It was basically literary research, sir. Since because we are not able to fit in the calf hypertrophy as well as the brachioradialis hypertrophy anywhere when dissociating. So when associating, literary research could reveal a transthyretin amyloid neuropathy, where we can have, there are case reports of variable autonomic dysfunction, sir. It is basically length dependent sensory motor polyneuropathy with variable autonomic dysfunction have been described in the literature, sir. So we put it as a DD where all the three symptoms can be explained, sir. Hypertrophy, thyroid neuropathy, tongue fasciculations with tongue atrophy, and the muscle involvement. All the three can be explained together in it as a DD, sir. Whereas the other diagnosis, we are not still able to explain what is the cause for the hypertrophy, sir, and the tongue atrophy as well. In other
Kalpana,
diagnosis, yes, sir.
is the hypertrophy known to occur in hypothyroidism?
Yeah, sir. Actually, I thought of a Hoffman syndrome also. But
Yeah,
with the
Hoffman or Debrecen. Yeah, Hoffman.
yeah, sir.
Hoffman.
But that was my first thought process when I saw the case first in the.
So why do you go for an amyloid? See that he may not have myopathic features, but this calf hypertrophy and so also brachioradialis hypertrophy would probably go in with the hypothyroid.
Yeah, sir.
And
I
you
thought
mentioned
hypothyroidism only, sir.
You
But
mentioned
what was
hypothyroid.
against is, sir? But what was against is, sir, with the TSH level of 15, this much of glycosaminoglycans can't accumulate, sir. Discussing with my friend endocrinologist, that was the thing I could infer, sir. With
Correct,
15,
but between amyloid and hypothyroid is more plausible. That's all I'm saying. And the
Yeah,
other
sir,
thing
yes,
is,
sir.
you mentioned hypothyroid neuropathy. How often does hypothyroid produce a neuropathy of this nature?
No, sir, it was just a differential only, sir.
The main differential history finding vasculitic neuropathy and hypothyroid neuropathy. Vasculitic neuropathy, perfect. Yes, agreed.
Yes, sir.
As Justin pointed out, with the connective tissue disorder, joint problems, arthralgia, and certainly you can consider a vasculitic neuropathy, which can explain both the motor, sensory, and I am not sure whether the vasculitic neuropathy. Justin, of course, said yes, in CIDP it can affect the facial nerve and the 12th nerve. But
yes, Matsam variant we can have, sir, an asymmetric presentation, but it predominantly starts with the upper limbs, no, sir.
Correct. To me, it doesn't fit in with the CIDP. I would,
yes, sir.
Yeah. But then, of course, we have differences in opinion, so it can be there. There are other people also. Others can participate, please. Quicker. Anybody having anything else to say? Prakash, Chitramalam, others are there. Shobhavati, Sendil. Allarum nare per irukanga, seniors. Megandan.
Sir, the combination of peripheral neuropathy plus arthritis plus tongue atrophy. But recently also 2025 they presented isolated tongue atrophy in gel-sol in amyloidosis, sir. So amyloidosis, not necessary that it should have very predominant autonomic symptoms.
Okay,
So,
you're quoting one finding and linking it with amyloid. Adha avungalum pannanga. Right, go
yes,
ahead. Okay, fine. Okay, anybody else? Anand is there.
Yes, sir.
Anand, Natesan, all Meganand sir is there. Okay, if there is nothing else, we proceed. There are 3 more cases. That's interesting.
Sir,
Yes.
Yeah.
Sir, one more point that patient has got painful peripheral sensory motor neuropathy.
Painless.
It is
Painless small
painless?
fiber neuropathy.
It's a painless neuropathy.
No, painful, sir. Their symptoms wise, they are telling it's painful.
Patient has got
Pain and
pain.
numbness.
Okay, fine.
The problem is whether the pain is because of joint or because of nerve.
Patient had burning painful sensation, sir.
Burning, yeah.
Yes,
Then
sir.
it is
So,
painful neuropathy.
predominantly,
ஏப்பா
yes, sir.
only on stimulus தானேப்பா?
சார் இல்லை சார் பேஷண்ட் ஸ்டிமுலஸ்லயும் பெயின் இருக்கு சார் பட் பர்சே வந்து ஹிஸ்டரி வைஸும் பெயின்ஃபுல் பர்னிங்
Okay, then go ahead. Okay, agreed. Okay, go ahead.
Painful sensory neuropathy with a large fiber involvement of the muscle weakness. You have got mixed picture with the suspected autonomic involvement. Autonomic involvement is not documented now.
Yes, sir.
And you accept for the tongue weakness and tongue wasting.
Yes, sir.
And so we have got a mixed picture now. And as Professor pointed out, in presence of hypothyroidism and sort of muscle hypertrophy, you have to suspect only the muscle problem, and we have to look for the CPK later after the investigation.
சரி
Rather
போங்க,
than-
இன்வெஸ்டிகேஷன் போங்க.
Okay,
Okay.
தேங்க்யூ சார்.
Welcome, sir. Mayanand, sir.
Let's go for the investigation. Let's see what happens.
Sir, investigation, hemoglobin was 11.2 and CBC total count was normal, sir. LFT and RFT was in normal limit. CK level was 110, sir. CPK level was 11. Serum calcium was 9.8 and electrolytes was normal. TSH was 15.64, sir, increase, sir. T4 level 16.69 and peripheral smear was normal, sir. Then CRP was 16.4, sir, positive. And ESR was 78, sir, increased. We did ANA, sir. ANA was negative. ASO was negative, sir. HbAg, anti-HCV, VDRL, VCTC was negative. And we did anti-musk antibody, sir. It was negative. And C-ANCA and P-ANCA was negative, sir. And C3 complement 181 and C4 complement was normal, sir. We did anti-CCP for this patient, sir. Anti-CCP also was normal, sir. And rheumatoid factor also we did, sir. Rheumatoid factor also negative for this patient.
Seronegative.
Yes, sir. Then we proceeded with 2D echo. 2D echo was normal, sir. CSF analysis was done in outside hospital, sir. It was normal, sir. And we did a nerve conduction study for this patient with the inference of motor mild achinopathy of right ulnar and moderate achinopathy of left ulnar and severe achinopathy of left median, bilateral tibial and bilateral peroneal, sir. And sensory conduction study revealed achinopathy of bilateral, moderate achinopathy of bilateral median and ulnar and severe achinopathy of bilateral sural nerve, sir. We did EMG for this patient, sir. EMG revealed neuropathic pattern for this case, sir. The MRI plain plus contrast was done from outside, sir. And MRI C-spine was done outside before coming to us, sir. So it was normal, sir. C-spine, there was a postocentral disc bulge at the level of C4, sir. We proceeded with muscle biopsy for this case, sir. We did a right vastus lateralis muscle biopsy. It revealed neurogenic atrophy, sir. And then nerve biopsy also done for this case, sir. Right sural nerve biopsy was done. Right sural nerve biopsy revealed vasculitic neuropathy, sir. There is no evidence of amyloid deposits in nerve or muscle biopsy, sir. So we came to diagnosis of seronegative rheumatoid arthritis with vasculitic neuropathy mimicking MND. And
Why mimicking MND?
Sir, since patient is having clinically, there is the involvement, the pattern of motor involvement is not like MND pattern, sir. And sensory also patient is having, so it is not
mimicking MND.
Sir, a patient is having tongue
minute,
atrophy,
Tongue fasciculation.
tongue atrophy and
Excuse me, sir.
fasciculation.
Alex, one minute.
One finding does not make an MND.
Sir, any baseline teaching for any PG is a tongue atrophy with fasciculations, we think of MND. That is the baseline teaching.
Any neurogenic involvement of the tongue will produce those findings, ma. There are others also. Appa na only sollala. Allegation, Justin, other features ella solunga pa, neenga solunga. Process.
Sensory involvement is solitama.
Okay, sir. Okay,
Don't
sir.
bring
Say,
this motor.
very severe sensory involvement, we can make a DDF from MND.
Sensory ன்னு commit பண்ணிட்டா MNDன்ற வார்த்தையே வரக்கூடாது.
Okay, sir. Okay, sir.
Okay, sir. Sorry, sir.
No, any neurogenic involvement can produce fibrillations and wasting.
Okay, sir.
Right. Continue.
So, seronegative rheumatoid arthritis with vasculitic neuropathy. That's all. And hypothyroidism here Percentage is not fitting for hypothyroidism. Okay.
எதுக்கு இப்ப அதை கொண்டு வந்த? What
Sir,
finding made you think of hypo? எதுக்கு கொண்டு வந்தீங்க?
sir, hypothyroidism patient already known case of hypothyroidism.
Okay,
sir.
associated.
Yes, sir.
Sorry, associated.
Associate.
Right.
After available of reports of biopsy and conclusion was made on vasculitic neuropathy, sir, and we got a rheumatologist opinion, and in the lines of vasculitis investigation was done and rheumatologist review was done, sir. They sir advised injection cyclophosphamide 1 gram and tablet prednisolone and syrup KCl, sir. So we proceeded with the first dose of injection cyclophosphamide on 31st 7 2025. So after cyclophosphamide injection review, sir, patient gait,
She improved.
she improved, sir. Yes, sir.
Yeah, we didn't see the gate before. அதனால நீங்க தான் சொல்லணும்.
Yes, sir. Patient improved, sir. And hand grip also, it improved very well, sir.
Right.
The cart itself started to move, sir.
Okay.
Coming to discussion, we did a literature search, sir. We ANCA-related vasculitic neuropathy mimicking MND, sir. Here,
பா, இங்க ஆங்காலாம் நெகட்டிவ் பா, அதெல்லாம் கொண்டு வராதப்பா.
yes, sir.
இன்னும் 3 கேஸ் இருக்குப்பா டிஸ்கஸ்
Yes,
பண்றது.
sir. Okay, sir. Then one more literature search, there was a tongue atrophy, fasciculation, transthyroid, familial amyloid neuropathy, sir. So broad classification of vasculitic neuropathy, systemic vasculitis and non-systemic vasculitis, sir, primary, secondary, and non-systemic, recurrent, and self-limiting, sir. So neurological manifestation of rheumatoid arthritis includes CNS manifestation, cervical myelopathy, meningitis, focal neurological dysfunction or optic atrophy. In peripheral nerve manifestation, there will be mononeuritis multiplex.
பா, இது ஆரே இல்லப்பா, விட்டுருப்பா.
Yes.
ஃபர்ஸ்ட்
Sir,
ஜீரோ நெகட்டிவ் ரைட்.
yes, sir. So rheumatoid arthritis, we did a score, sir. Score was 7 for our patient, sir.
Did the rheumatologist agree to rheumatoid arthritis?
Yes, sir. Yes, sir.
Okay, then proceed. Okay.
Zero negative rheumatoid.
Zero
Okay.
negative
Yes.
rheumatoid arthritis.
Okay, continue.
Sir, yes, sir. We searched for literature review also, sir, for seronegative rheumatoid arthritis present with vasculitis. We got only one case presentation, sir.
No, allegation, sir, was saying in a rheumatoid arthritis with high cervical involvement, you can get hypoglossal nerve involvement. அதுக்கு ஏதாவது இருக்கா?
இல்ல சார், லிட்ரேச்சர் சர்ச்ல கிடைக்கலங்க சார்.
சரி, ரைட். அதான் allegation சார் சொன்னாரு.
Yes, sir.
அதுக்கு ஆன்சர் பண்ணிடு.
Yes, sir. Yes, sir.
Several cases have been reported, sir. Panus formation in the Atlanta axial joint can cause 12% case reports are there, sir.
Yes, sir. இதுல பேனஸ் இருக்குன்னு எப்படி சொல்றது allegation, sir?
So we have to take MRI cervical spine plane and contrast, sir.
என்னப்பா அலெக்ஸ், என்ன இதுதான்?
இல்ல சார், எம்ஆர்ஐல வந்துட்டு வெறும் C6ல மட்டும் ஒரு ராடிகுலோபதி ஃபியூச்சர்ஸ் தான் சார் இருந்துச்சு. வேற
Not much in the MRI C-spine, sir.
கிளினிக்கல் எக்ஸாமினேஷன்லயும் லாங் ட்ராக் சைன்ஸ் எதுவுமே இல்லைங்க சார். யோமன் சைன்ஸ் எதுவும் இல்லைங்க சார்.
ஓகே, ரைட்.
History
அப்புறம் வேற
was
என்ன
not supporting
கல்பனா,
the-
வேற என்ன மேடம் சொல்லணும் அந்த கேஸ்ல?
Sir, இல்ல சார், ஆக்சுவலா I was not able to explain this tongue atrophy with fasciculation,
Correct,
sir.
அம்மா.
அதனால literature searchல
எங்களாலையும் சொல்ல முடியலமா?
சார்,
அம்மா,
அதான்
instead
ஒரு
of-
நிமிஷம் சார்.
Don't know தான்.
Okay,
One
sir.
second. One second. Instead of calling it as rheumatoid arthritis vasculitic neuropathy, as Justin pointed out, it is autoimmune mediated vasculitic neuropathy rather than because the anti-CCP is negative and all the other things. Even though the rheumatologist has accepted, just because he has accepted, you need not say it is rheumatoid arthritis.
மேகண்டன் சார், ஆட்டோஇம்யூன் சொல்றதுக்கும் ஒன்னும் சப்போர்ட் காணுமே.
Sir,
CRP is raised. CRP is raised.
CRP any inflammation, பாருங்க, CRP can be raised in any inflammation. Don't say that it's autoimmune.
Kalpana, you have done the ENA profile?
எல்லாம்
Yes, sir.
சொல்லுப்பா, ENA ப்ரொஃபைல் என்னப்பா?
ENE profile was negative, sir.
ஆ,
ANA also was negative for this case, sir.
ENA நெகட்டிவ்னா அப்புறம் என்ன ANA? ரைட்.
Patient was on any steroid previously before?
No,
landing?
sir. She was on traditional medications occasionally, sir. Like for 1 week or 2
several-
weeks only she took, sir.
ஏப்பா ட்ரெடிஷனல் ஆயுர்வேதிக்கா?
Sir,
Several auto
Ayurvedic
antibodies.
medicine, sir.
ட்ரெடிஷனல் ஆயுர்வேதிக் இருக்குதா?
Ayurvedic, sir. For 1 week
Oh.
only she took, sir, for pain. But over the counter alone, she was taking analgesics alone, sir.
Several auto
Maybe steroid may be
antibodies.
the underlying, that may be the reason for negative reports, lab reports, probably.
There is an autoimmune component has to be accepted, sir, because of the thyroid, because of the peripheral neuropathy, joint pain, all those things. Definitely.
Sir, usually
Last week somebody presented some SCL 70 positive antibody, something like that. There are several antibodies which we are yet to probe into in autoimmune antibody.
Okay.
Again, this patient had sudden loss of weight. Within 2 years, the patient has lost some 2 to 3 kgs. That's what she said, that the conspicuous loss of weight, there may be paraneoplastic also.
Anyway, she is improving with cyclophosphamide. அதுக்கப்புறம் இப்ப என்னமாச்சு? இப்ப என்னப்பாச்சு?
Sir,
Sir, she is currently on the second dose, sir, on follow-up with us.
Okay. Right. Continue to follow up and let us know. ஏன்னா இன்னும் 3 கேஸ் இருக்குப்பா எல்லாம்.
Yes, sir.
Sir, actually, I put this case we are still yet to know the cause for the muscle hypertrophy, sir. And
Sir,
tongue
we have to ask,
fasciculations and
Kalpana madam, we have to dissociate this
Okay,
muscle
sir, okay,
hypertrophy
sir.
that is due to hypothyroidism. So we cannot associate
Okay,
all
sir.
these things together. The
Okay, sir.
hypothyroidism would have caused the muscle hypertrophy.
மேடம் விஜயன் ஒரே ஒரு பாயிண்ட் சார் ஒன்னு சொல்லிக்கலாமா?
ப்ளீஸ் 4 பாயிண்ட் சொல்லுங்க. You are welcome.
இல்ல மேடம் எக்ஸலன்ட் மேடம் ஃபார் அது this is definitely a confusing case and she's done an excellent workup. The nerve biopsy, vasculitic neuropathy and then treating the patient excellent. What is the age of the patient, madam? I joined late. I'm sorry.
40s.
40.
sir. Sir, 39 years.
40-year-old.
30. ஓவரி சேவிங் ரெஜிமென் எதுவும் கொடுத்தீங்களா? அதுக்கு தான், வேற ஒன்றும் இல்லை.
Sir,
ஓவரிஸ் ப்ரொடெக்ஷனுக்கு கொடுத்தீங்களா? சைக்ளோபாஸ்மைட் கொடுத்தீங்களே?
she's got 2 children, sir, already.
Family.
Okay.
Completed family, sir.
Otherwise, it's an excellent workup, madam. Even I wouldn't have thought of this. It almost. I also thought it was MND when you said tongue fasciculations and atrophy. Excellent.
Thank you,
To go up to that extent and do a nerve biopsy, demonstrate vasculitis, and then link both together and treat her successfully is wonderful. Thank you, madam.
Kalpana, you have done an excellent work at Kanyakumari.
Thank you, sir. Thank you, sir.
Yeah. Okay.
Okay,
Yes, sir.
thank you.
Finally, but seronegative rheumatoid arthritis is the diagnosis. So there's no confusion that it can be a widespread condition. They have finally worked it up as seronegative rheumatoid arthritis with the
Sir,
vasculitic neuropathy.
sir.
So
Okay,
there's
sir.
no,
Okay, sir.
and the associated hypothyroidism confusing the picture. And nowadays we don't think about motor neuritis alone when tongue atrophy, because we see a lot of MuSK antibodies, MuSK myasthenia. And
அதனால தான் பண்ணிருக்காங்க அவங்களும். They have thought about it and done it also.
Gelsol amyloid presenting as only tongue atrophy. So this is a very finely worked up case, and final diagnosis is definitely seronegative rheumatoid arthritis with the vasculitic neuropathy with a atypical tongue atrophy as part of the disease. So there's no confusion in that, sir. That's the final diagnosis. Beautifully worked up, sir.
Very
Alex,
good work,
nicely
Kalpana.
presented.
Keep
Thank you,
doing,
sir.
keep doing.
Thank you to
Very good work.
this Kanyakumari Medical College team, Dr. Kalpana and the postgraduate
இன்னும் 3 கேஸ் இருக்கு. Wait.
And next is, that's why, sir, we will go to the second case by
Abhisheka, sir.
The Vipshana Uttam Rao Manwar or Abhisheka, the second
Abhisheka,
case.
sir. Second case is Abhisheka, sir.
என்ன கேஸ் அது?
Okay. Then the invitation is written as Uttam Rao. Okay, right, okay.
என்ன கேஸ்ப்பா? Oh,
Sir,
granuloma.
this is
Then
granuloma,
Granuloma
sir.
disease. Right.
Yes, sir.
டைட்டில் ஒரு மிஸ்டரியா தான் இருக்கு. ஐம்பது நிமிஷம் ஆயிடுச்சு ஜவஹர்.
So this case, I think we can go quickly. We'll see.
பார்க்கலாம். கேஸ்க்கு தகுந்த மாதிரி பார்த்துக்கலாம்.
Good morning to all. I thank Dr. Kalpana ma'am and sirs for giving me this opportunity to present in this forum.
Abhisheka, go ahead.
Yes,
Present crisply, ma, fast.
yes, ma'am. Thank you. 19 years old male studying BSc Computer Science, right-handed individual admitted with history of tremulousness both hands since 8 years of age and history of weakness of both upper limbs since 8 years of age, history of sensory disturbance in both hands for 1 year. History of presenting illness, history of tremulousness since 8 years of age, which was insidious onset and non-progressive in nature, aggravated on approaching an object, and he also finds difficulty in writing in the form of tremulousness while holding a pen while writing, though he could manage to eat without smearing of food and drink water without spilling. History of unsteadiness while walking in the form of swaying while walking in narrow pathways since 8 years of age. History of weakness of both upper limbs since 8 years of age in the form of difficulty in writing, buttoning, unbuttoning, but there was no history of difficulty in reaching objects in height. Also, there was no history of flaleness, stiffness of limbs, and weakness was non-progressive in nature, and no history of weakness of lower limbs. History of sensory disturbance of both hands for past 1 year in the form of reduced perception of hot and cold sensation, initially started in left hand, followed by right hand over a period of 3 months in medial aspect of both palms. History of bending of medial 2 fingers of both hands for past 1 year, started in left hand, followed by right hand over a period of 4 months, associated with worsening of weakness of both hands for past 1 year in the form of difficulty in gripping objects, gripping pen while writing, though he has good scholastic performance, and history of dryness of mouth and eyes since 2 years. History of able to perceive smell, able to see clearly without any diplopia, color vision is normal and no restricted field of vision, able to move eyes in all direction, no drooping of eyelids, able to perceive sensation over face, no slurring of speech, no history of giddiness, vertigo, tinnitus, reeling sensation, able to swallow without any nasal regurgitation, able to stretch shoulder and manipulate food in mouth, no history of loss of consciousness, seizures, involuntary movements and headache. No history of bowel bladder abnormalities, no associated giddiness, postural syncope, sweating, flushing and palpitations, no history of back pain, radiating pain, no history of twitching of muscles of muscle cramps, no history of diurnal variation or weakness and fatigability, no history of shock-like sensation on bending neck, no history of rash over face, psychiatric symptoms, joint pain and hair loss, no history of toxin exposure, no history of substance abuse, no history of drug intake. Past history, history of recurrent painful parotid swelling over since 8 years of age, on and off symptomatically treated in local hospital. History of recurrent painful neck swelling since 8 years of age. FNAC from the swelling taken at 8 years of age, not taken any long-term treatment and details not known. No history of seizures or any thyroid disorders. Personal history, mixed diet, normal sleep pattern, not an alcoholic smoker or any drug abuse, normal bowel bladder habits. Birth history, born out of cesarean section, cried immediately after birth, no NICU admission, history of mortal milestone delay present, neck holding at 6 months and sat with support at 8 months, walked with support at 2 years of age. Normal language and milestone and normal scholastic performance. Family history, history of tremors present in mother, sister and history of tremor present in father and grandfather. So summary of history, which is a 19-year-old male studying BSc Computer Science with underlying history of delayed motor milestone, presented with chronic non-progressive gait ataxia with intentional tremors, both upper limbs, with the chronic non-progressive distal weakness of both upper limbs since 8 years of age, with worsening of weakness over past 1 year associated with the clawing and sensory disturbance over medial aspect of palmar surface of both hands, with the history of recurrent parotitis and cervical lymphadenopathy since 8 years of age, without any history suggestive of any cognitive, cranial nerve, extrapyramidal or autonomic dysfunction. So history localization, first tremulousness, I would like to localize in bilateral cerebellar hemispheres and its connections, weakness, sensory disturbance over medial aspect of bilateral hand and clawing of medial 2 fingers. I would like to localize for peripheral nerve, that is bilateral ulnar nerve, and dry eyes and mouth, recurrent parotitis and cervical lymphadenopathy to rule out any underlying autoimmune cause. So from the history, I would like to go for the differential diagnosis of early onset cerebellar ataxia, but which is in this case it is non-progressive and with underlying history of dry eyes and cervical lymphadenopathy, dry mouth, we would like to rule out any Sjogren or sarcoidosis. General examination, patient conscious oriented, no pallor, not icteric, no cyanosis, no goiter. Schimmer's test, it is less than 5 mm per 5 minutes. And cervical lymphadenopathy 2 x 2 centimeters, non-tender, not matted cervical lymph node left side, bilateral clawing of 4th and 5th fingers present, bilateral ulnar nerve thickening present, no neurocutaneous markers, no other markers of HIV, syphilis, no markers of skin nodules, rash, telangiectasias, dryness or scaling of skin or loss of hair, tendons, xanthomas, tonsils normals and nail normal. vitals normal, memory, language, speech normal, MMSE 30/30. Cranial and other first cranial normal, second normal, third saccades low, pursues broken, oculomotor attacks apraxia with blink assisted saccades present, and other cranial nerves normal. This is the video of pursuit. The pursuits are broken, and this is the video of oculomotor apraxia.
எங்க பார்க்க சொல்லுங்க பார்க்கணும் சரியா விரல பாரு பெண்ண பாரு விரல பாரு விரல் பெண்ணு விரல் பெண் பெண் விரல் பெண் விரல் பெண்.
So he couldn't initiate the saccades to both side, more on towards right side. Other cranial nerve examination normal, bulk normal with the right hypothenar wasting, intrinsic muscle wasting present on both hands. Tone upper limb normal, lower limb spasticity present. Power neck flexion extension normal, trunk normal, shoulder flexion extension and wrist which is suggestive of some premenal pattern of weakness with hand grip 80% of both sides. Hip abduction, adduction, flexion, extension, which is 4 minus and 4 flexion 4 minus and extension 4. Knee and ankle suggestive of pyramidal pattern of weakness with small muscles of hand, both abductor pollicis brevis, opponent's pollicis, flexor pollicis brevis weak, adductor pollicis weak, and other hypothenar muscles also weak with the dorsal palmar interosseous abduction, adduction, and lumbricals also shows weakness. Superficial reflexes normal with the plantar bilateral equivocal. Deep tendon reflexes, biceps 2+, finger flexor present, supinator 3+, bilateral, trapezius 2+, knee 3+ bilateral, and ankle 4+ bilateral with ill-sustained clonus on both sides. Sensory examination, pain, temperature, fine twitch and reduced over medial aspect of palmar aspect of both hands, and vibration joint position normal, rhombox negative. Cerebellum, bilateral finger nose test, finger nose test impaired left more than right, heel shin test impaired left more than right, but rebound phenomena negative, no dysdiadochokinesia, no nystagmus, and tandem walking impaired, intentional tremor plus. This is the video showing tandem walking with finger nose test and finger nose test which is impaired more on left side than right side. Extrapyramidal system normal.
Tandem walking காமிங்கம்மா. அந்த வீடியோ ஒர்க் பண்ணல. Tandem walking.
Cannot play media. It's not working.
Okay, forget it. Right, proceed.
Sorry, sir, it is not working. Spinal cranium, no spinal tenderness, no gibbous deformities, no signs of meningeal irritation, gait normal. Other system examination, perianal sensation normal, anal tone normal, other system examination normal. Summary, 19 years old male studying BSc Computer Science with underlying history of delayed motor milestone, presented with chronic non-progressive gait ataxia with intentional tremors, both upper limb with chronic non-progressive distal weakness of both upper limb with worsening over past 1 year associated with the clawing of medial aspect of both hands with the sensory disturbance medial aspect of palmar surface of both hands with the history of recurrent parotitis since 8 years of age. On examination reveals dry eyes, reduced salivary pool, non-tender, firm cervical lymphadenopathy, non-mated cervical lymphadenopathy, and neurological examination reveals oculomotor apraxia, slow saccades and broken pursuits, insidious onset, non-progressive spastic quadriparesis with bilateral motor sensory ulnar neuropathy with bilateral ulnar nerve thickening with appendicular ataxia left more than right and gait ataxia without involvement of higher mental function, cranial nerves, extrapyramidal and autonomic nervous system. So structures involve spastic quadriparesis. I would like to localize in bilateral corticospinal tract, appendicular ataxia, bilateral cerebellar hemisphere and its connections, oculomotor apraxia, which is from Cogan's type, cerebellar vermis and vestigial nucleus, and gait ataxia vermis, bilateral clawing and sensory disturbance, bilateral ulnar nerve. So differential diagnosis, if we associated the symptoms and signs, spastic quadriparesis with ataxia and oculomotor apraxia with neuropathy with recurrent infection, first differential diagnosis ataxia with oculomotor apraxia, bipyramidal signs, parotitis, cervical lymphadenopathy couldn't be explained. In ataxia telangiectasia or ataxia telangiectasia like disorders, age is a bit earlier than this, but no telangiectasia, no truncal ataxia, no sinopulmonary infection, and also it is non-progressive. So we would like to dissociate the symptoms and signs. Spastic quadriparesis and ataxia, which is non-progressive with oculomotor apraxia, we would localize in mixed CP, and bilateral ulnar neuropathy with dry eyes, dry mouth, recurrent parotitis, cervical lymphadenopathy. We should rule out sarcoidosis or underlying Sjogren's.
So,
Wait.
your first differential diagnosis you put not the association. So, because this patient is having non-progressive cerebellar ataxia, non-progressive pyramidal signs, and delayed milestones, all these things suggestive of some static problem which has happened from the birth onwards. So, your the later dissociated diagnosis that mixed CP is the ideal one. Even oculomotor apraxia is reported in mixed CP. But
Yes,
the only thing for the past 2 years, he is having that bilateral ulnar neuropathy, sensory motor with
Yes.
clawing. That is only that occurred. So you have to definitely differentiate, dissociate both these findings.
Okay.
So that is due to bilateral ulnar neuropathy is due to what you are telling could be due to.
Sir, bilateral ulnar neuropathy since 1 year with the underlying history of 2-year onset dry eyes, dry mouth. With the
So you are thinking of
cervical lymphadenopathy, I should rule out some underlying autoimmune cause like Sjogren or sarcoidosis, sir.
sarcoidosis.
Jawahar,
Yes.
there are some pediatric neurologists. Meghanak
Yes.
sir is there, Ramakrishnan is there, Senthil Kumar is there. How many of them agree to this being a mixed CP?
Sir, Ramakrishnan, sir.
We were
Yes,
first
Ram.
shocked.
Yes, Ram. Go ahead, Ram.
Sir, definitely we will not agree with the diagnosis of mixed CP, sir.
Thank you.
Because for such a least common type of CP is ataxic form of cerebral palsy. The spastic quadriparesic CP, generally, they will not even attain head control, able not to suck or swallow. So this much of studying BSc computer science will not be acceptable for the diagnosis, sir. And it is less likely to be mixed CP. More likely, it could be autosomal recessive spastic ataxia of Charcot-Marie like that, sir. Because he has got ataxia, he has got pyramidal signs, and he has got oculomotor apraxia. So more likely it should be ARSAX.
Arax.
That is more likely, sir. So mixed CP, definitely it doesn't look like a mixed CP, sir. And this
Ramakrishnan sir, but this is not progressive. So since from childhood, the cerebellar ataxia, pyramidal signs, all these things not progressive, it is static.
Yes,
Only
sir,
thing,
but see, sir, spastic quadriparesis is the worst form of CP, sir. It is the one where there will be maximum disability. Usually, if you see spastic CP quadriplegic type, they will be having associated microcephaly, they will be having associated seizure disorder, associated visual impairment, all those things will be there. Spastic CP quadriplegic child, they will never walk, sir. You can ask Meghanak sir also, Senthil sir also. He will not study BSc computer science. Definitely, that will not be the diagnosis, sir.
Yes, sir. We were first shocked when we heard it is spastic ataxic spastic ataxic cerebral palsy, because we have never seen a child like this growing up to this stage. And except for the motor milestones, no other milestones. What about his writing, learning, and all those
Everything
things?
seems to be normal, sir, because he's studying BSc second year, where he's able to read well, write well.
Nowadays, I always say that it's very difficult to assess with that, because up to 10th standard, they are all given pass.
Yes, sir.
And after 10th standard, they use a scriber to finish off +2. and then see, and by giving some, I don't know, I don't want to get into the politics, but they become computer science because the right brain working alone is enough for. Okay. But it is not cerebral palsy, as you point out. Cerebellar science and cerebral palsy, as such, is with the pyramidal science. We have to accept that with a pinch of salt. It is extremely difficult, as you pointed out, that oculometaparaxia with ataxia and all those things are against the diagnosis, though it is non-progressive. We still do not know that it is non-progressive as he grows further. Is there any family history, madam?
Sir, no history of any ataxia in family history,
But
sir.
tremors is there.
There is tremulousness is there, but as per history, they are telling like essential tremor like history, sir.
There's history of other people having tremulousness.
Yes, number of people.
Yes, sir. In mother's side also, mother's sisters, mother's side cousin, and father's father is having tremors, sir.
But among the early onset cerebellar ataxia with non-progressive features, can it be a cerebellar hemisphere or Vermean agenesis or dysgenesis?
Yes, sir. That is more likely, sir. If there is early onset, non-progressive. But generally, I have not seen these oculomotor hyperaxias in these kind of congenital cerebellar hypoplasias or agenesis, sir. And this pyramidal signs also generally not that common, sir. They will have pure ataxia, which will be non-progressive in nature. They will generally don't have associated eye findings also.
What about the other group of symptoms like recurrent keratitis, loss of drying of mouth and things like that, which she has mentioned? Do they fit in with anything, or that is to be considered a separate entity?
Sir, I feel it looks like separate, sir. May not be. For example, if at all we take ataxia, telangiectasia, they can have recurrent infection, sir. But he's not having any telangiectasia. But by this time, he would have really had recurrent infections, which will be really serious, sir.
Sir, in this case, there is a delayed milestone, sir. Delayed milestone, non-static bipyramidal signs, and there is like asymmetries also there. Left is more involved than the right side. And brain-assisted saccade, that probably shows to difficulty in initiation. Okay? Everything can be localized at the cortical level. But in the video, I am not convinced about the cerebellar signs in coordination.
I am also not convinced.
I am not convinced.
I am not convinced. But we didn't see the tandem gait.
What about
the tremor? It doesn't look like an incoordination.
So what about CT, sir?
So why can't it be a static spastic CP, the asymmetrical onset? Asymmetrical.
No, it is not. It doesn't fit in with cerebral palsy at all. And what about CT scan brain, madam? CT or MRI? Anything has been taken?
Yes, sir.
They have not gone for the investigations yet. Okay, go ahead. Continue. Let's see.
Investigations. CBC, RFT, LFT normal with ESR 26 mm per hour. Serum calcium normal. TSH normal. Peripheral smear reactive lymphocytosis. And CRP is normal, ASO negative, HbSAg, HCV negative, HIV VDRL negative, uric acid normal, anti-CCP is negative, C3, C4 complement normal. Since there is bilateral ulnar neuropathy, we would like to rule out the leprosy. So triple S negative. And to
Madam, one minute. Why do you want to rule out leprosy? Oh, because of the ulnar nerve.
Ulnar neuropathy, we were.
Correct. Thick and ulnar nerve also.
Only ulnar nerve, sir. Bilateral ulnar nerve. So split skin smear negative. To rule out sarcoidosis, we did the serum ACE levels, 24 hours urinary calcium normal, CT chest, CD abdomen normal. To rule out Sjogren, ANA negative, SSA, SSB negative, limb biopsy normal. To rule out ataxia telangiectasia, serum AFB also negative, sir.
Again, exhaustively investigated. Very good.
Thank you, sir.
Continue.
Manto test which was positive, sir. So we did a cervical lymph node biopsy which shows lymph node with multiple confluent granuloma with epithelial histiocytes and spotty necrosis, caseating tuberculous lymphadenitis, which was AFB positive, sir. This shows epithelioid cells and also caseating necrosis, sir. This is the NCS of this patient. Left ulnar now amplitude was reduced, and sensory, which was normal, sir. Suggestive of left ulnar, electrophysiologically suggestive of left ulnar moderate motor axonopathy, sir. This is the MRI brain of this patient showing right hemisphere atrophy with evidence by the dilatation of right temporal horn, frontal horn, and the body of lateral ventricle, bilateral hyperintensities in white matter changes, both corona radiata. These findings were suggestive of mild perinatal insult with the bilateral hippocampus T2 flare hyperintensity, suggestive of mesial temporal sclerosis. With arachnoid cyst 18 cross 10 mm in a right CP angle, and cervical spine was normal, sir.
Continue.
So, since cervical lymph node biopsy was AFP positive, we started with the ATT. And since the patient is having dry mouth and dry eyes, since 8 years of age, we were not convinced with only the presence of tuberculosis. So, we searched for articles regarding
What is
tuberculosis
the
and
evidence
sarcoidosis
for sarcoid?
coexistence.
Why did you suspect sarcoid? Just because he had dry eyes and dry tongue?
Yes, dry mouth with cervical lymphadenopathy since 8 years of age, sir. If it is only tuberculosis, it would
But
have.
AFB is positive.
Yes, AFB is positive, sir.
Continue.
In tuberculosis, peripheral neuropathy, tuberculosis per se does not cause peripheral neuropathy, but we should rule out other coexisting causes like HIV and diabetes and tuberculosis drugs like INH and ethambutol induced peripheral neuropathies. In tuberculosis parotitis, which is very rarely in literature, only fewer than 100 cases were documented, sir. But it will be presenting as acute diffuse swelling or chronic localized lesion. It is chronic, so it should have localized lesion if it is tuberculosis, sir. And in tuberculoma of peripheral nerve also common, sir. Total 7 cases of reported in one article. All in all cases, ulnar nerve is involved, sir.
All rare manifestations of tuberculosis you have got hold of.
Thanks.
Tuberculosis with leprosy picture.
Yeah, tuberculosis with sarcoid, tuberculosis with leprosy, all associations. Okay, continue.
Okay, sir. In dry eyes and tuberculosis, literally search, there some cases are presented as sarcoidosis and tuberculosis coexistence, sir. With the clinical pattern of 3 pattern can be possible, sir. With prior TB, with later sarcoidosis, which can be due to immune hypersensitivity. With sarcoidosis with latent or occult TB, sarcoidosis if treated with immune suppression may uncover or reactivate tuberculosis, or simultaneous active TB and sarcoidosis were also reported but very uncommon, sir.
Madam, do you subscribe to Occam's razor, or do you say it's Hickham's dictum?
Sir,
Which one
actually,
do you
sir, I'm convinced with there is tuberculosis. Agreed, sir. Combining the spastic quadriparsis with the cerebellar signs, sir. I thought of putting as mixed CP, sir, because we need to dissociate the dry eyes, dry mouth with the.
So you are going for a Hickham's dictum, whereas your postgraduate is going for a Occam's razor, putting everything to tuberculosis.
No, sir. Actually, I had a doubt whether it is only tuberculosis, because tuberculosis is not able to explain all the features, sir.
That's what I'm saying. You are dissociating. You are putting in multiple diagnosis, which goes with Hickham's dictum, whereas she is eliminating everything and saying everything is tuberculosis, which is.
Sir, we have presented here for all your thought process, sir. Whether we are not sure of the diagnosis, sir. We are standing upon an ATT.
Now I just brought in this. There are so many learned people. They will contribute.
Okay, sir. Okay, sir.
Sir, she is discussing about only the relation between tuberculosis and sarcoidosis. She is not telling this case is due to tuberculosis. Just
in the case of tuberculosis,
in the case tuberculosis, sir, but the symptoms are not related to the tuberculosis. Even ulnar nerve palsy in tuberculosis, I never found out. In literature they reported, but
she is very rare because she wants to put everything to tuberculosis. That's one diagnosis. She is going for one diagnosis. Whereas Kalpana is going for multiple diagnoses. But anyway, let's see the audience, what they have to say.
Sir, can it be a leprosy where we'll have a AFP also positive, sir?
Nama?
Yes, sir. The 6 days need taken, sir. It was negative, sir.
But histology,
how to differentiate, madam?
HP
Yes, sir. If it is leprosy, it is more predominant of sensory only, sir. Sensory predominant. And also in a cigar bundle will be seen in the histopathology, sir.
Oh, histopathology where done? Where it was done?
In the lab, ma?
Sir, in
Iman, sir.
Trivandrum, sir. Sir, in Trivandrum,
Oh.
reputed lab, sir. Reported at Ernakulam, sir.
Okay, okay.
I spoke to the pathologist also, sir. He was very sure of this case sheeting random.
As Jawar sir mentioned, involving the ulnar with the tuberculosis is difficult to accept. That is the problem.
பரவாயில்ல நம்ம டிஃபரன்ஷியல் சொல்லுவோம். So
ஆமா sir.
Hansen ulnar neuropathy. What about the other presentations? What do we put it as?
Yes, sir. But patient would be having a pre-existing some mixed CP or we should follow up, sir.
CP தான் மூணு pediatric neurologists have said no to CP. So then it can't be accepted.
Yes, sir. We should follow up the case for progression of ataxia, sir. Then it should be degenerative ataxias. Some attacks like sir.
அது ஒண்ணு leprosy neuropathy இன்னொன்னு அப்புறம் இன்னொன்னு sarcoida என்னது அது இன்னொரு diagnosis for the parotitis and the dry mouth and dry tongue அதெல்லாம்.
Yes, sir. But we did the serum AC levels.
தெரியுமா எல்லாம் நார்மல் எல்லாம் non contributory.
Sir, if at all there is a progressive degenerative ataxia, MRI would have picked up by this age, no, sir. 8 years duration. But it is non-progressive. Degenerative ataxia are quite progressive, no, sir. We don't find anything in the MRI regarding the cerebellum. There is not even a prominence of the cerebellar folia. Why there is going to be an atrophy in the right hemisphere, sir? With the prominence of the temporal horn, that should be explained by what, sir?
Yes, sir. Meganan, sir. Ramakrishnan, sir. Senthil.
There is no cerebellar atrophy, isn't it? Cerebellum is normal. Yes.
Sir, definitely MRI findings are difficult to explain, but this MRI will not make us put the diagnosis of cerebral palsy, sir. That amount of atrophy is not there. And this mesial temporal sclerosis, that is very unlikely to be related to hypoxia also, sir. So even though MRI doesn't show cerebellar atrophy or show findings of any progressive ataxias, MRI is not in favor of the diagnosis of HAE also, sir.
But when MRI definitely rules out a cerebellar disorder of ARCA, classical ARCA, and the patient has symptoms from birth, we'll have to call it only a birth-related injury, and probably this is an atypical way. Probably in olden days when CPs, all CPs were expected to be very severe, probably imaging was not that popular. So now, since the symptoms are present from birth, and since the patient does not have isolated cerebellar features and definitely has features of long insult, I mean chronic insult, probably we should call it only a birth-related injury, and birth-related injury is only called with motor features is called CP. So I would like to call it a CP only. So CP with tuberculosis.
Why do you want to call it as birth-related injury? It is birth-related. Stop with that.
Yes, sir. Injury is not necessarily hitting with. Injury can be hypoxia also. So this is hypoxic injury. And the diagnosis, if you want to put, I will put it as mixed CP with tuberculous sarcoidosis. So that becomes a full diagnosis. So mixed CP with the tuberculous sarcoidosis. Probably tuberculosis is there with sarcoid features. Whether this tuberculosis has induced a sarcoidosis or tuberculosis presence like sarcoidosis, you can even call it a tuberculous sarcoidosis. But the diagnosis about the cerebral condition is not ARCA, so it is only a birth-related injury, and that is CP. A birth-related injury is only CP.
Sir, excuse me.
Chitrambalam, sir.
Yes, sir.
The CP is not an image diagnosis. It's a clinical diagnosis, and the pediatricians favor it. They are very definite. This does not fit into the CP diagnosis.
Sir, we don't expect CP to be so severe. So the severity is not the one which is going to define a CP. CP, various features like cognitive decline may not be so severe that...
Spastic paraplegia irukpa. Spastic paraplegia irukku significant.
Sir, patient need not be cognitively bad. So the various components like epilepsy, cognition, motor, speech, all can be dissociated. So this patient has more of autonomic, more of motor features. He doesn't have a cognitive feature. He doesn't have epilepsy. It all depends upon the area of injury during the perinatal insult. So Still it
But
is only a
those who are
CP, sir.
those who are seeing day in and day out CPs, the pediatric neurologists, they are not
Yes,
at
sir.
all convinced it is CP. Not one,
Yes,
two.
sir.
Three
That
pediatric
is
neurologists
based on
are
traditional.
convinced.
Yes, sir. That is based on traditional belief. But we have a definite clinical and radiological evidence that there is an injury, and it rules almost all other
Sir,
arcans are ruled out.
please don't be dogmatic. Don't be dogmatic. It doesn't
Being
look like,
dogmatic, we
sir.
can't refuse all diagnosis because at the end
Sir,
we have
can I
we have
come
the
in for one
clinical
moment?
picture, we have the radiology, everything.
Yes,
At the
Vijayan.
end, we should be able to tell
Sir,
something.
I wanted to know again, excellent workup of the case by Dr. Kalpana.
Yes, of course.
One more. I just wanted to know, madam, did you do a tissue PCR for TB? The same question that Dr. Professor Justin asked, I also have in mind. Can't it
Gene
still be
expert.
leprosy?
Gene
Tissue
expert,
PCR.
sir?
Gene expert or tissue PCR? Tissue PCR.
No, sir. No, sir. Actually, the whole
That
note
would
they
have.
gave it outside, sir. At that point of time, I was confident that it would be a Sjogren's, sir. I didn't think of tuberculosis. I thought Sjogren's would be definitely positive because tumor was positive, recurrent parotitis, everything fit into Sjogren's, sir. So I gave the biopsy. Then they made a paraffin block, sir. So not able to retrieve the tissue again for the gene expert, sir.
Yeah, only tissue PCR would have helped in clarifying whether from the
Yeah,
treatment point of
Sjogren
view.
is different. Either leprosy or tuberculosis is only for the ulnar now, ma. But that is totally different.
For treating the patient.
Things.
For treating the patient, not for treatment. So maybe.
The biopsy, sir, the biopsy was done only for the cervical node. Then where is the question of leprosy involving the cervical node? So the biopsy was not of a nerve.
Yeah, sir. Ulnar nerve, we can't take it for biopsy, no, sir.
You can have a superficial sensory ulnar nerve.
Ulnar nerve you can do, madam. We do dorsal ulnar nerve. You can dorsal digital branch of ulnar nerve. You can do biopsy of that. It is commonly done dorsal, or you could have done this one also.
Branch of the ulnar nerve we have done, sir, many times here also.
Yeah, ulnar nerve very commonly done. Dorsal digital branch of ulnar.
Nephrologist opinion,
usually doing sural nerve, sir. Yes, sir. Yes, sir.
Nephrologist opinion, unga nephrologist or dermatologist.
Dermatologist, they didn't opine anything concretely, sir. Maybe tuberculosis.
Dermatologist cannot be called for a pure neuritic leprosy. Only if there is a skin manifestation, they will be able to opine. Many times you've seen pure neuritic leprosy. The dermatologists are not able to give any opinion, and their split skin biopsy, all these things turn out negative. Only if you do a muscle no biopsy, you will be able to find out. So I think there's no big role for a dermatologist here because it is not a serious one.
Sir, Chitrambalam sir.
Yes,
one more thing is you can ask to do a split skin biopsy on the nerve distribution. That also might show leprobacilli sometimes. That commonly shows leprobacilli. Apart from the dorsal digital branch of ulnar nerve, in the skin distribution, you can do a split skin biopsy there of the nerve involved. You will get leprobacilli. That's also.
Since we have evidence for tuberculosis in some area, and there are literature search has shown that tuberculosis can involve ulnar nerve. Probably at this juncture, we'll have to take it as a tuberculosis involvement of the ulnar nerve. So, and I think that settles the diagnosis.
I don't think it settles the diagnosis, but working diagnosis, fine. Thank you.
Sir, I have one query.
Presenter, does tuberculosis explain the tremor? Does it explain the spastic paraparesis? That also, is it explained by tuberculosis?
No, sir. No, sir.
Definitely not.
Some pre-existing condition, sir, for the patient.
Yeah, ma tremor varudhu. Tremor is CP oda manifestation, amma.
Sir, the tremor is intentional type, sir. So it.
Amma, adu vandu CP manifestation,
Mixed CP, we can get other system involvement other than pyramidal tract. No, sir. Extrapyramidal as well as cerebellum can be involved in a mixed CP.
Ataxic CP can have a intention tremor, sir.
Yes, sir. Yes, sir. Ataxic CP.
அதான் அவங்க pediatricians அப்பா pediatric neurologist இருக்காங்க கன்கர் பண்றாங்களா கேளு.
No,
sir. This is a standing problem which is present from birth. So until proved otherwise, this is a perinatal insult. And from the MRI, we are very sure that it is only
just because it is.
Even if traditionally people have not thought about mixed CP in such cases, please let them think from hereafter.
Sir, this is a asymmetrical bipyramidal science, sir. Asymmetrical bipyramidal.
No, sir. It is actually
showing outside focal atrophy.
There is a family history. There's an immunocompromised boy, and the keratoconjunctivitis sicca, and he has got
no immunocompromise, sir. No evidence of immunocompromise so far.
He had this type of disseminated tuberculosis in a child since childhood, isn't it? He had the symptom since the age of 8 years. What about his handwriting like? And did you do the handwriting? Last time also I asked this. Whether he was able to sign well. What about his writing? What about his calculation like?
Sir,
Did you do any
MMC
cortical
was
function?
30/30, sir. The handwriting is not so poor, sir. It was normal only, sir. With some difficulty in holding pen.
With the intention tremor, will he be handwriting will be normal? Have you taken any sample of his writing?
Sir.
No, sir. No, sir.
No, sir.
You have not asked him to write and see how he is writing.
Yes, sir.
And
He
simple
has
calculation.
difficulty in writing, sir. That was the complaint told in
How
the
come-
history of
how
present illness,
come-
but we didn't make him write, sir.
For
And
MMC,
what did he say? He was progressively worsening in his handwriting. Was it worsening?
no, sir.
No, sir. No, sir. It was non-progressive, sir. Actually, cerebellar symptoms are non-progressive. Presently, what for he has come is this recurrent parotiditis as well as lymphadenitis was more troublesome, and also this ulnar neuropathy, no, sir.
Joints.
That is also troublesome, which has brought him to the hospital. Those
So
cerebellar.
we are missing some spinocerebellar ataxia of the family type where familial type where there is an associated sort of keratoconjunctivitis or Sjogren-like picture. All those things are that something we are missing somewhere.
Okay, we'll go to the next cases, sir. There are 2 more cases. Also
Yes, sir.
interesting, perhaps.
I think this is a very complicated case.
Yeah, all cases are complicated from her. But you have done an extensive workup, ma. You have done an
Thank
extensive
you, sir.
workup.
Sir,
which,
I
which
have
even,
queries, sir.
even in Chennai, we may not be doing so much of workup. Okay.
Thank you, sir. Sir, I have a
Congratulations.
query here, sir. Please, sir, can I ask?
Yes.
Sir, actually, what for I have put this case in this presentation is I'm convinced that it is mixed CP, sir, as far to my knowledge, because of non-progression of cerebral
Please
ataxia.
get yourself convinced that it is not mixed CP.
Thank you, sir.
It is
Thank you, sir.
mixed CP.
My-
No,
Sir, in
definitely
fact,
we
it is a
cannot
mixed
explain
CP.
any other by any other
No, you
being
can conduct
non-stat.
a voting and I will put 5-6 vote, color vote also. It is only mixed CP.
Sir, it's non-progressive cerebellar and spastic quadriparesis. Why we have to be hesitant to think of cerebral palsy? We can think cerebral palsy.
Jawahar,
If
how
you don't
sure-
want to call it cerebral palsy, coin some other word. Yeah, perinatally acquired static cerebellar dysfunction like that. You can coin some word, but it is the same. It just means the same. Some injury that has occurred during birth that is
There is
static,
no
that is
entity.
to the
Sir,
cerebellum.
there is no entity called cerebellar palsy.
Sir,
Jawahar,
Yes, sir.
Jawahar,
Yes.
how sure are we that it is non-progressive? Has anybody examined this? 1 minute. Has anybody examined this patient previously? Till this age, somebody must have examined him. What were the findings? Unfortunately, we don't seem to have that. So if we had had
See,
that,
sir, one thing is that there is
The
a delayed
progressive cannot be
milestones.
this 19 years. He cannot do this much of qualification and this much of motor activity is not possible in a progressive one, sir.
it is not
I
possible in
have-
the CP also. That's what they are saying.
Sir, I have got several
They are
children.
saying it's not possible in CP also.
Sir,
This can-
sir, in the
That
MRI,
is what we are. That's what we are differing, sir.
sir,
Yes, sir. Go ahead, Ram.
சார் ஆக்சுவலா இந்த எம்ஆர்ஐ இந்த ஆக்சியல் T2 போட்டிருக்காங்கல்லங்க சார், அது ரொம்ப ஃபோக்கஸ்டா பார்த்தா ஐ ஃபீல் தெர் இஸ் செரிபுலர் அட்ரஃபி இருக்கு, கொஞ்சம் வேர்மியன் அட்ரஃபி இருக்கு, பிரெயின் ஸ்டெம் அப்பியர்ஸ் கொஞ்சம் ஸ்மால்ங்க சார். குட் பி இந்த பழைய காலத்துல சொல்ற ஒலிவோ போன்ற செரிபுலர் அட்ரஃபி அந்த பிக்சர்ல வர மாதிரி இருக்குங்க சார். நம்ம எம்ஆர்ஐ ரேடியாலஜிஸ்ட் கொடுத்த ரிப்போர்ட் அப்படியே ஐ திங்க் வி கான்ட் டேக் இட் நினைக்கிறேங்க சார்.
Sir,
Go ahead, Kalpana, go ahead.
I have discussed this with several of the radiologists, sir, known radiologists. Actually, in our institute, we don't have an MRI, sir. Private institution only, we have to send the patients and get an MRI done. Private reporting from Pranav is the report which has been posted, sir. In spite of that, we have asked several people, sir. They are just telling about the right cerebral hemisphere atrophy with the predominant temporal horn. But again, we've asked for the cerebellar picture, sir. None of the radiologists give any clue to
Cerebral
this.
hemisphere seems to be normal.
I seem to accept totally your radiologist diagnosis. To me, it looks right only.
And also there are
Or-
delayed
or-
milestones. Delayed milestones that also we have to take into account in favor of.
That means it's an injury much earlier.
Differences
not-
in opinion accept பண்ணிக்கங்கப்பா.
Right, sir, right, sir, right. We can. I think we can go ahead with the
Yes.
third case. Already is time getting late.
The presentation is only for this, bringing out all aspects. If there are various opinions, let's accept it. Okay.
Thank you very much, Dr.
Wonderfully
Kalpana,
worked up, sir.
என்ன
Chitrambalam, for your feedback.
Chitrambalam,
Okay.
என்ன சொல்றீங்க?
Wonderfully worked up, sir. Thank you.
Huh?
Thank you.
That's
Thank
right.
you, ma'am. Thank you, sir.
She has done whatever is possible in her setup.
Dr.
More than that,
Ramakrishnan,
more than
everybody. Thank you.
Thank you, sir.
Thank you all.
Dr. Uttam Rao Manwar, there's a third case, unraveling the mystery of diagnostic dilemma in a case of cerebral ataxia.
வேற ஏதோ பேர்ல வந்தது.
Uttam Rao, Vipshana, Uttam Rao Manwar. Vipshana.
Show the first slide.
Oh, full name
Vipshana
அப்படி
Uttam
வருதா?
Rao.
Right. We'll have more discussions. Go ahead. Interesting.
It's an interesting case, sir. It provokes a lot of discussions and
இன்னும் வருது. Wait.
it's a boxing round. Actually, everybody is fighting with each other. It's an interesting thing. Good.
ஒன்னும் தெரியலனா we'll all fight with each other. Ma present. Go ahead.
Vipshana, present.
Vipshana, your voice is not hearing. I'm not able to hear the voice. Unmute your mic.
Viparshana.
You unmute your mic, Vipshana.
Sir, I'm calling her, sir. I'm calling her.
Host unmute பண்ண சொல்லுங்க. Host Vipshana unmute பண்ண சொல்லுங்க.
Yes, sir.
Just check whether she has unmuted the mic.
Not able to hear. Not able to hear.
We can go for the next case.
Then we can go for
அவங்க
the
ரெடியா
next
இல்லனா அடுத்த கேஸ்க்கு போயிடலாம்.
case. Sir, she is unmuted, sir, but not able to hear. She is calling me, sir.
Sun team, can you help her, please?
Yes, sir. Inform, sir. Just now inform to the host.
Yes, sir. Yes, sir.
Yes, please, sir. Thank you.
Sir, we can go to the fourth case, sir.
If she's not,
Yes.
you can go to the other case and come back.
I think fourth case we can go quickly. This is yes, Dr. Kalpana. Yes.
Yes, sir.
Okay.
Good morning, all. My name is Dr. Anisha Ashraf. I would like to thank Sedhuram sir and Dr. Kalpana ma'am for helping for giving me this opportunity to present in this forum. Thank you, everyone. My case is the steroid responsive mystery. History: a 64-year-old right-handed individual who is a carpenter came with chief complaint of drooping of right eye for 3 days. He was apparently normal 3 days ago when he had complaints of drooping of right eye, insidious onset, progressive, no aggravative or relief factors, no symptom complaints in left eye. History of double vision, both images lie horizontally, worse on seeing near objects, no history of fatigability, patient was not aware of clear and blurred images. He was able to perceive color, no history of decrease in luminosity, floaters, flashes of light, no other cranial nerve dysfunction, no history of any headache, no history of weakness in both limbs, sensory disturbance, seizures, no history suggestive of bulbar dysfunction, no cerebellar dysfunctions. Past history, no comorbidities, no toxin exposure, no addictions. No chronic alcoholic and smoker, otherwise no toxin exposure, no native drug intake. Personal history, mixed diet, chronic alcoholic smoker. Summary: 64-year-old male with no known comorbidities, with complaints of acute right eye drooping of right eye, with double vision, with no history of any eye pain, without involvement of other cranial nerves, with intact spinomotor, sensory, cerebellum, and pyramidal system, extrapyramidal system. General examination: patient is conscious oriented, afebrile, grade 2 clubbing, no neurocutaneous markers, no syphilis malignancies, no skin lesions, parotid swelling, skeletal deformities, tonsils, thyroid, salivary pool normal. Vitals was normal. Cranial nerves, optic nerve was normal. Olfactory nerve normal.
Yeah, one nimsham. Go to optic nerve. Visual acuity is 6/24, 6/18 போட்டீங்க நார்மல் இருப்பீங்க.
6/24 and 6/18 sir. Visual
You mean to say refractory error?
Yes sir, refractive error sir.
சொல்லணும்ல.
Yes sir. Other cranial, oculomotor, trochlear, abducent, elevation impaired, depression impaired, intorsion affected, extorsion affected, adduction affected. Abduction is intact, accommodation is affected. Complete ptosis is present, and no nystagmus, pupillary size is normal, and reaction to light, direct or indirect reflex, accommodation was normal, accommodation reflex could not be assessed. Trigeminal nerve sensory sensation decreased in V1 distributions. Other corneal conjunctival normal. Facial nerve is normal. Renes test was normal. Vestibulocochlear nerve was normal. Glossopharyngeal nerve was normal. Spinal accessory normal. Hypoglossal nerve normal. Spinomotor system, sensory system, cerebellum, extrapyramidal system, spine and cranium normal. Bilateral carotids normal. Bilateral temporal artery normal. All pulses well. No peripheral nerve thickening. Gait normal. Other systems all normal. This is the video showing extraocular movements where patients elevation videos. Sir, video is not
Nisha, play the previous video. Play the previous video.
I'm not working.
Can
I'll show the photo. It is
Kodak
not...
unavailable. It's not available. File is not available. Okay, go ahead.
Okay, so I'll show the photos. Sir. All extraocular elevation, depression is impaired in the photos. Intorsion, extorsion, adduction is affected. Only abduction is intact. So provisional diagnosis was acute right eye pupil sparing partial ophthalmoplegia. Structures involved were right fourth cranial nerve with V1 distribution. Localization was predominantly cavernous sinus. Etiology predominantly infective, inflammatory, metabolic, and neoplastic.
Duration 1 week, amma.
Yes, sir.
Okay, go ahead.
So etiology. First, infective causes we thought of, sir. So we did workup, complete blood count are normal, peripheral smear, only showed mild eosinophilia. Patient is then CSF analysis we did to rule out any fungal meningitis and all can predominantly cause multiple cranial nerve palsies. So that's why we did KOH mount, AFBs, and tuberculous meningitis also can cause cranial nerve palsy. So CSF analysis we did, everything was normal.
1 minute. What was the corresponding blood sugar level? Your sugar is 38 milligrams. CSF sugar.
CSF.
What was the corresponding blood sugar?
Sir, normal,
We
sir.
don't know.
78. Sir, he's 78, sir, not diabetic, sir.
No, okay. Right, continue.
VDRL, we thought like predominant infective causes which can cause third, fourth, sixth cranial nerve palsy was tuberculosis, syphilis, Lyme's he was not willing, sir. Lyme's serology and all. So we did what all was available in our hospital, sir. And other causes, second we thought of metabolic. He was not diabetic, sir. And other cause which can other investigations were normal, sir. Urea, creatinine, RBs, everything was normal, sir. Not diabetic. Other causes we can think was Wernicke's encephalopathy and protein electrophoresis.
Is it Wernicke's encephalopathy?
No, sir. Metabolic causes, sir. It can cause third, fourth, sixth. Not in this case, and I'm talking about other metabolic causes, sir, which can cause third, fourth, sixth cranial palsy. And multiple myeloma, to rule out multiple myeloma also we did protein electrophoresis, sir. So that was also normal, sir. Then third one is autoimmune. ANA was negative. IgG4 serum was normal. ACE levels was normal. C-ANCA, P-ANCA was normal. Autoimmune causes usually SLE, sarcoidosis and all, Sjogren's, sarcoidosis and all can cause, but predominantly sarcoidosis will cause 7th, 8th cranial nerve involvement, and SLE can cause multiple cranial nerve involvement, sir. And Wegener's granulomatosis all can cause multiple cranial nerve involvement. So to rule out all this, we did all this workup, sir. Next is polyneuritis cranialis also, sir. Next is neoplastic, sir. MRI is normal, sir. Neoplasm, which we can suspect was meningioma, if it can involve the sphenoid wing meningiomas or pituitary tumors also, it can involve the cavernous sinus and nasopharyngeal carcinoma, but usually nasopharyngeal carcinoma 6th and 12th nerve involvement is common, sir. And sinusitis.
Did you do the MRI brain contrast?
Yes, it was normal, sir. No meningeal enhancement, no space occupying lesion.
No, just
small vessel
show the
ischemic
MRI
changes.
brain contrast. You see here, MRI brain contrast.
Only small vessel ischemic changes, sir.
No. MRI brain contrast only, that the previous slide. Yes, here. Here in the second row, third slide, this cavernous sinus on one side, right side is slightly more enhancing than the second, third. 1, 2, 3. Second row, third, mid. Here. The cavernous sinus, when compared to the left, right is slightly more enhancing. See, yes. This type of presentation usually happens in the Tolosa hand. Okay.
Then inflammatory causes. ESR was 30, sir, and C-reactive protein was also elevated. So our final diagnosis was right Tolosa Hunt syndrome with atypical presentation. We gave treatment of steroids, sir, antibiotics.
What was the atypical presentation?
Sir, no headache, sir.
No pain.
That's not an atypical presentation.
No pain, sir. Here
no pain. No pain.
Sir, no pain, sir.
But this is an anterior cavernous sinus syndrome, correct?
Yes, sir.
Yes, sir. Right third, right fourth, and right V1.
Yes, sir. Third, fourth, and V1 distribution, sir.
So probably a non-inflammatory anterior cavernous syndrome.
Yes, sir.
நீங்க ஒரு extensive differential diagnosis வச்சுட்டு எல்லாத்துக்கும் investigate பண்ணிட்டு இருந்தீங்கன்னா I don't think that's proper. See, our differential diagnosis should be 1 or 2. I mean 2 differential சொல்லும்போது. And investigate for that. Why do you want to have so much of investigation?
Sir, Tolosa Hunt syndrome is a diagnosis of exclusion, no, sir. So we have to exclude other causes to name it as Tolosa Hunt syndrome.
List of autoimmune, metabolic, infective,
Sir, all these conditions will cause multiple cranial nerve
investigate பண்றீங்களா? Is it required in கேக்குறேன்?
Sir, cavernous sinus we did not think because there was no chemosis, no redness, no proptosis, sir. And all these conditions usually it will cause third, fourth, and trigeminal nerve distribution, so that is why we thought to rule out all the other causes.
It's an syndromic classification. It's an anterior cavernous syndromic classification.
Yes, sir.
Because it involves 3, 4, 5, V1 without involving the optic nerve.
Yes, sir. Yes, sir.
Yes. So அதுக்கு 1 week duration. இதுக்கு நான் சொல்றது keep the differential diagnosis to 2 and investigate only for that. நம்ம extensive list of DD போட்டுட்டு ஒன்னொன்னுத்துக்கும் investigation நீங்க present பண்ணிருக்கீங்களே அது அவசியமா? That's what is my question.
Okay, sir.
Diagnosis of exclusion, sir. So we have to exclude everything, sir. Even now I am not accepting a Tolosa Hunt. We have not excluded. We have to do a biopsy of the lesion. Unless we do a biopsy, we have not excluded.
சிற்றம்பலம் நறுவில இருந்தா அதான் சொல்லுவீங்க. ஆனா நாங்க இன்ஸ்டிடியூட்ல இருந்து இந்த மாதிரி கேसेस என்ன பண்றோம்? ஸ்டீராய்ட போட்டு என்ன ஆகுதுன்னு பாக்குறோம். அவ்வளவுதான் வித்தியாசம்.
இது ஆப்கம்ஸ் ரேசர் இங்க தான் சார் வரணும்.
எவ்வளவு நாளைக்கு ஸ்டீராய்டு போடுவீங்க? அதெல்லாம் இருக்குல்ல.
Sir, in this case, can we call this as Tolosa Hunt syndrome? Because according to the international classification
Tolosa Hunt
ஒரு nebulous criteria, pain is necessary to diagnose the Tolosa Hunt, sir.
As you know, Tolosa Hunt is a nebulous entity. What is Tolosa Hunt ன்றது தெரியாம இருக்கு. It's accepted, not accepted, எல்லா வெர்ஷன்ஸும் இருக்குது. நீங்க சொல்லுங்க. Sorry, you continue. Whatever you are saying. சொல்லுங்க.
According to the international classification of the headache disorders, to make a diagnosis of the Tolosa Hunt syndrome, we need to have a pain, sir. Without pain, we cannot call this as a Tolosa Hunt. We can call Tolosa Hunt like
Tolosa Hunt like syndrome.
For which we have to look for other causes.
Sir, otherwise, Tolosa hunt is quite normal, sir. Everybody knows, sir. We have put here because it is an atypical, because there are case
Correct,
reports
Amma.
presenting
Agreed.
without pain, sir. And
Agreed.
Tolosa hunt இல்லன்னு சொல்றதுக்கு Tolosa hunt இருக்குன்னு சொல்றதுக்கு சார் IgG4 sarcoidosis-ல ரூல் அவுட் பண்ணாதான் Tolosa hunt-ஆனே சொல்ல முடியும்.
Ma, you have done so much of other investigations, Amma. நீங்க
Okay, sir. Agreed, sir. Agreed.
அதுதான் சொல்றேன் நான்.
Kalpana,
Okay,
if you want to say Tolosa hunt, then you should fit with the clinical criteria, or you should take a biopsy. Then only we can call this as an atypical Tolosa hunt.
Since they have ruled out all the other causes and patient finally responded to steroids, so they come to conclusion.
No, sir.
அப்ப மட்டும் என்ன diagnosis வருது ஜவஹர்? நீ
அதான் சார்
எல்லாத்தையும்
somebody says steroid responsive.
IgG4 is
Steroid
not ruled.
responsive,
IgG4 levels
Tolosa
do not
hunt.
rule out, sir.
அப்ப again you are coming to an inflammatory pathology.
Sir, are you ruling out IgG4 by just the levels of IgG4? Do we not? You can rule it out only by a biopsy afterwards. So
அவ்வளவுதான்.
still, I
போடுங்க.
feel IgG4 is not ruled out, sir.
Right.
And sarcoidosis, where did we rule out sarcoidosis? We have not ruled out sarcoidosis. ACE levels are increased only if sarcoidosis specifically involves lungs. Otherwise, ACE does not rule out. If at all it is elevated, it helps, but otherwise it doesn't rule out. So
What
this
is
case,
ruled
I
in?
feel-
Chetrambalam, what is ruled in? சொல்லுங்க. Forget ruled out.
IgG4 on MRI brain contrast will show the pachymeningitis or some meningeal enhancement. All these things will be there.
Not initially, sir. Not necessary that at the presentation itself. It may take some more time for the pachymeningitis to come, sir.
No,
Only if it is missed, probably they have gone to a good institute, so that is picked up first itself. Otherwise, if you see after 3-4 months, then you can have a pachymeningitis along with all these features. But still,
IgG4 with the cranial neuropathy, most commonly they will show the MRI will show the enhancement, pachymeningitis, all these things. Here, especially only in the cavernous sinus area, there is enhancement. The most likely is this thing. What is that? Tolosa hunt. Sarcoidosis, yes.
Tolosa hunt is a diagnosis exclusion. It's a very painful orthoplegia. So,
Yeah, that's
Chetrambalam, the second para இருக்கிறது அந்த investigations are absolutely accepted. அது ஒண்டினா ரைட். அதை தவிர பாக்கி இன்வெஸ்டிகேஷன்ஸ் தேவையில்லைங்கிறது நிறைய பண்ணாங்க, நிறைய லிஸ்ட் அவுட் பண்ணாங்க அவங்க.
இல்ல சார், அவங்க என்ன பெட் கூட பண்ணல. That is another basic investigation in all these doubtful cases.
என்னது?
Electrophoresis is given in the exclusion criteria, sir. Need to be done. Lyme also given in the criteria, sir.
Yes,
International accepted criteria, diagnosis of exclusion, they have given all these lists, no, sir.
Chitrambalam will not accept any diagnosis without PET.
Sir, patient responded. That is why we did not do biopsy.
அம்மா நான் பண்ண சொல்லமா, சித்ரமலத்துக்கு சொல்லுமா.
Sir, one more thing. Can I add in one?
Yes, Vijayan.
I think no more workup can be done in this case. 1. 2, you cannot do a biopsy of that reason. I am sure no one can be able to do it. It's an anterior cavernous sinus syndrome, which has multiple differentiated diagnoses, responded to steroids. We have to wait and watch. Petanol is definitely not going to add to the diagnosis. I'm sure it's not.
Vijayan sir,
We have worked with so many cases with anterior cavernous sinus syndrome. It is not going to add to the diagnosis. No.
If you have a biopsiable lesion outside, like a cervical node or something, that will help you. Not that
அதுதான்
it's
பண்ண
a must,
முடியும்
I am
சார்.
telling.
இது பண்ண முடியாது. இது டெஃபினட்டா பண்ண முடியாது.
Sir,
And
biopsy
initial cases of
inquired, sir. Sir, biopsy we inquired, sir. Our institute were not able to do, sir. We don't even have
Madam,
an
no
MRI in
institute
our
can do that. No institute can do that. If you see Tolosa Hunt's original description, most of the cases were biopsied, and all the cases that biopsied died.
Okay, sir.
Yeah. So no one can do that.
In the case,
It is a non-infective granular.
I am not telling you, you go inside the brain and do biopsy of this case where the lesion is not very visible on MRI. I am telling you, if it is, if you want to really document it, you need a biopsy. That's what I am telling. I don't say you have to do the biopsy in this case. But if you cannot get a accessible lesion,
You should have been very clear when telling biopsy. And a biopsy of the lesion is not possible. That much.
I am not telling this case, sir. Only for final diagnosis we need biopsy, I am telling. And if you do not do a biopsy of intracranial lesion, that is the idea of PET. PET is it will tell you where there is any accessible site. For example, in the cervical node, if you have, or somewhere else you can do a biopsy. That's what I am telling.
Okay.
And you can't say PET is not necessary. I will say PET is necessary. If the patient can afford, if your hospital has, you can definitely do PET for this patient.
So in these type of cases, we have to exclude all the vaginous granulomatosis, sarcoidosis, and any fungal infection. All these things in this area to be ruled out before we diagnose this
Angal
tolerance.
again agreed, sir.
Javakar sir, I am asking, if just because the patient responds to steroids, what does it mean? You just tell me, just because the patient responds to steroids, does it mean anything in diagnosis?
It means only
No,
it's
no,
an
it-
inflammatory lesion. Chitrambalam,
What-
it only means
what-
it's an inflammatory lesion, no specific diagnostic part.
Yes, sir. Then if you want to make a specific diagnosis only, you will have to do all those. That's what I'm telling. Because the future follow-up becomes difficult. If you don't make a specific diagnosis, follow-up becomes difficult only. This is what we come across in case of optic neuritis and everywhere. If
Right,
you are
that
not
is
able to
what
make
Vijayan said in the natural
sir.
course of events, having seen so many cases, this is
Yes,
what
sir.
happens, and this is fitting in with the picture. That's what he says.
Just, I'm also not telling a dogmatic diagnosis. I'm just telling it is an anterior cavernous sinus syndrome, which has responded to steroids. You can wait and watch. I think
Yeah, even if you do
they've
a
done
biopsy, it's going to be a
wonderful job.
granulomatosis.
ஆமா அதான் வரப்போகுது.
Yes.
Let's go ahead with our next.
Next case.
That's
Yes.
all over.
Sir, that's
Oh,
fine.
okay. Continue on.
So it is
You
a
make
rare-
your presentation, whatever you want.
So it's a rare symptom, sir. It is idiopathic granulomatosis inflammation of the cavernous sinus. So it responds to steroids.
ஆனா நீதான் டொலசாண்ட் இல்லன்ட்டியா பெயின் இல்ல அதனால டொலசாண்ட் இல்லன்ட்டியா
Atypical presentation,
சொல்லல
sir.
sir.
We didn't tell, sir.
இல்ல, அவங்க
Atypical
they are going
presentation,
to.
sir. Because
criteria, sir, criteria.
Because usually criteria we need unilateral orbital periorbital headache, and then the second criteria we need granulomatous inflammation of the cavernous sinus superior orbital fissure, paresis of one or more ipsilateral oculomotor trochlear abducens nerve, and third, in it full headache ipsilateral to the granulomatous inflammation, headache has preceded the involvement of extraocular nerve by 2 weeks, and other causes we should rule out. So this patient headache was not there, and it was not painful ophthalmoplegia. So that is why we thought a diagnosis of a typical Tolosa Hunt, sir. So this is
Sir,
an article, sir.
Sir, this is a case report, sir, with painless ophthalmoplegia. There are case reports, sir. This is an atypical
Correct.
case only, sir. This way.
Yeah. Raj Gokul, are you there?
Kalpana,
ஏப்பா ராஜ்
Yes, sir.
கோகுல்
Yes, sir.
இருக்கியாங்க
Yes, sir. Yes, sir.
in this case, your case report, the MRI is positive. But your case, the
Sir,
MRI is normal.
MRI may be positive in the after a few weeks also, sir. There are case reports also where MRI can get a positivity after 4 to 8 weeks. It's given in the literature, sir. There are case reports as such. There are some case reports like that, sir. Without MRI positivity.
Javakar feels MRI is abnormal only. Dr. Javakar feels MRI is abnormal
Actually,
only.
in Tolosa hand, you won't have a very classical dramatic MRI picture, only asymmetrical, slightly cavernous sinus enhancement that you have to suspect Tolosa hand. We don't see any bright contrast enhancing cavernous sinus lesion. Many times we are picking up in this way only. So in this patient, I have seen a Tolosa hand with variable intensity of the pain. Some people will have excruciating pain. Some people will have very, very mild pain, only or nagging paresthesia, something like that. So it is possible still the patient can have without pain presenting as a Tolosa hand. It's possible.
Raj Gokul,
Sir, yes, sir.
in the Shine meeting, they presented a case where it was suspected Tolosa hand. Do you remember
yes.
what were the features in that case? Cranial nerves presentation present பண்ணாங்க அது.
Yes, sir. Actually, patient did not have any third or fourth cranial nerve palsy, sir. Only 5-1, 5-2, and the 6th cranial nerve palsy was there in that patient, sir.
What about pain?
No pain, sir. Patient did not have any pain, sir.
And how did they establish Tolosa hand?
Facial numbness alone was there, sir, and not a unilateral headache, sir. It was a holocranial headache was present throughout. No periorbital pain, sir.
Yeah, but how was the diagnosis established?
Sir, after ruling out all the other causes, possible Tolosa Hunt Mari we kept, sir, but still there was a meningeal enhancement, pachymeningeal enhancement was there in MRI for that patient, sir.
Okay, but
There will be no Tolosa Hunt.
The pachymeningeal environment indicates that there should be either sarcoidosis or
IgG4.
IgG4, all these things.
Yes, sir.
Okay, right. Go ahead.
Actually, that case, after seeing that case, I told Raj Gokul, sir. Similar case we also have in our district. I was telling him, sir. With a similar case.
கல்பனா பேசுறீங்களா?
Yes, sir. Yes, sir. Raj Gokul is my junior PG, sir. I told him that we also have a similar case when he presented in Shine, sir.
Correct. Yes.
Okay.
அதனால தான் கேட்டேன்.
Right, go ahead.
A
Yes.
rare variety of Tolosa angina with painless ophthalmic region. Classic symptoms, headache was not there, sir. So diagnosis relies on imaging and steroid response. And long-term monitoring is needed for relapse or to rule out any alternate diagnosis.
Okay, thank you very much. We'll go to the next case. Is Vishwapriya is available there? Yes.
Yeah, she has come up. Vipshiana. Slide share பண்ணுங்கம்மா. Enlarge your slide. Again, audio work பண்ணலையா?
No, sir, that problem was sorted out, sir.
Then why is she not able to speak?
Slide show வரலையே. Must start presenting, ma.
Still the speech. Hello. I think she has
Sir,
not.
I think some problem with the audio, sir. I will ask her to present from the mobile, sir.
Then the
Okay,
mic, just see whether the mic is unmuted or not. That's
Yes, sir. Mic is unmuted only, sir.
Totally voice is not audible.
Okay, let her present from the phone.
Anybody else can present this slide. If any other person can have, they can present this slide. Other postgraduate.
No, but the audio should be there, Jawar. She has to speak, no?
Sir, shall I present, sir?
Okay, go ahead. Yaar Kalpana வேணுமா?
Yes, sir, yes, sir.
Go ahead, go ahead.
Am I audible, ma'am?
Yeah. Present,
Yes,
present.
yes.
Thank God.
Audible.
Yes,
Thank
great.
God.
Put it on slide share, ma.
Good afternoon, all. Myself,
Open your
Vipassana.
slide. Put it on slide share as you did before.
Yes, sir.
That's
Now
right.
visible, sir.
Yes.
Presenting the next case, sir, the unraveling the mystery, the diagnostic dilemma in the case of a cerebral ataxia. So case is 48-year male, right-handed individual, studied up to the 12th standard, auto driver by occupation, ex-alcoholic and smoker. So this is the chief complaint. This is the first episode. Fever followed by the fever for 1 week, mild to moderate grade, occasional chills, 1 to 2 episodes per day, without any rigorous night sweat, evening rise of temperature, not associated with any cough, cold, or dysuria. Followed with myalgia, which after this fever got over, myalgia was still persistent about almost for the 3 weeks, even after resolution of the fever. 2 months later, the patient noticed unsteadiness while walking, speech disturbances, tremulousness of the both upper limb, difficulty in using left upper limb and lower limb. All the symptoms were on the left side, it was more than the right side. So unsteadiness while walking, he started having imbalance while walking at home, narrow pathways towards the bathroom. And his wife noticed that he walked like a drunken person with sway to the either side. Audible?
Yes, go ahead.
Yes,
He started holding on the wall while walking without any difficulty in bending his knees, tightness of the legs, buckling, any worsening in the dark, and abnormal sensation over the feet, no history of dizziness.
But this was the first episode, huh?
Yes, sir. This is the first episode, sir. He noticed slurring of the speech while talking fast, strained voice. Progressively, it was slow with pauses while saying the words. Gradually, it became difficult to comprehend. He did not have any change in tone, like a nasal twang, no tremulousness, no outburst of the loud outburst during the speech. He had no difficulty in understanding and reading. Coming to the next complaint, tremulousness of the both upper limb. He had developed the tremulousness of the both hand while trying to get a glass of water to drink. Worsened before the reaching object. Often the water would spill on his clothes. He also noticed that when eating the food, it would be smudged on the face. He had no tremulousness at the rest. Difficulty in using left upper limb and lower limb in the form of holding object, changing auto gear, lifting object, getting overhead object, difficulty in walking, going upstairs, lifting leg above the ground. However, he was able to do all these things with the right upper limb and lower limb with tremors. So coming to summary and the symptoms analysis, this is a 48-year male right-handed individual, known case of the cervical spondylosis, present with fever followed by the subacute onset of tremor, unsteadiness, incoordination of the movement,
head nodding affecting his day-to-day activity without any aggravation of the symptoms on the eye closure, without cognitive domain involvement, cranial nerve involvement, extrapyramidal, sensory or autonomic dysfunction. So structures involved
Amma,
for
1
the
minute, 1 minute.
yes, sir, yes, sir.
How long after the fever episode, February episode, did he
almost
get
2 months.
2 months.
Yes, sir.
Okay.
Should I proceed, sir?
Yes.
So structure involved for the unsteadiness and the ataxia is a gait. Vermis. Then for tremor, bilateral tremor is a intentional tremor for which bilateral cerebral hemisphere left more than right. Dysarthria is possibly a scanning type of speech, localizing to left superior paravermal region, and the left hemipresis, which are localizing to right corticospinal tract, sir. Should I move to the next slide, sir?
Continue.
So differential diagnosis could be first was a subacute onset of vascular pathology. Then second is as it is followed by a fever and myalgia episode, we thought of secondary as a post-infectious cerebralitis. Third is could be the paraneoplastic or autoimmune. And last, in this scenario, Whipple's we have kept as a DD, sir.
Why vascular? What vascular you suspected?
Sir, patient has all cerebral symptom with left hemiparesis also, sir, which was subacute onset almost, sir. So in this short duration, either toxin, vascular, or the paraneoplastic or post-infectious.
Continue.
So with above complete, patient was admitted in KGMCH. Investigation were done where MRI brain shows no infarct. LPCSF was done to rule out cerebralitis features or infection. So CSF protein was 48 and CSF culture were negative. Patient provisional diagnosis was made as a subacute onset post-infectious cerebralitis and started on the injection methylprednisolone 1 gram IV for 5 days, followed by the oral steroids and other treatment like the antiplatelets, antibiotic, gait training, speech therapy, after which the patient has a drastic improvement of his all cerebral symptom. Within the few days, nearly almost 75 to 80% of the improvement was seen.
What happened to the weakness, unilateral weakness?
Sir, it was also there, sir, but much improved, sir.
Okay.
All the symptoms, almost 75 to 80% improvement in the symptom were there. And patient was discharged with the tapering doses and on regular follow-up. So this was in the April, sir. Now coming to the second episode, in around June, after 3 months later, the patient developed acute onset, fever, low grade, associated with the chills, without any diurnal variation, loose motion, 2 to 3 episode, watery, foul smelling, non-blood stain, associated with the abdominal pain, cough, cold, myalgia, and worsening of all the cerebral symptom. Previous fever was not associated with any symptoms during fever episode. After 2 months later, only cerebral symptoms came. In this second episode, fever was associated with all the worsening of all the cerebral symptom. So patient again readmitted with the following complaints and had the GI symptom along with the worsening of the cerebral symptom. So we re-evaluated the patient to rule out any other cerebral cause. So we proceeded for the UGI-scopy to rule out any Whipple's or celiac disease, which shows pangastritis, duodenitis with duodenal biopsy shows chronic inflammation. Peripheral smear to rule out any acanthocytosis, but it was negative. Fever workup including dengue, leptos, scrub typhus, vidal, malaria was negative. Patient again started on the methylprednisolone for 5 days, followed by the oral steroid, doxycycline tablet, and physiotherapy. And in this episode also, there was a partial improvement in the gait ataxia and the dysarthria, sir.
HIV was positive or negative? HIV was done?
Negative, sir. Negative, sir. So I will come to investigate.
Sidrama, I couldn't hear you. What did he say? HIV, yeah?
HIV, sir. Negative.
Okay.
Coming to the third episode, this is the current episode, so last month, August, almost 1 year later. Patient has a fever on and off for 1 month, low grade, not associated with any chills and rigor, not associated with any night sweat, no urinary disturbances, associated with the malaise. History of loose motion, cold, worsening of the cerebral symptom, but milder than the intensity as previous June episode. So during the hospital stay, patient claimed sensory symptoms over the lower extremity up to the both knees in the form of initially pinprick sensation followed by a numbness, associated with the unaware slippage of the slippers and stop using slipper while walking. And the worsening of the unsteadiness on the eye closure, increased titubation, incoordination, swaying towards the left side more than the right side, and history of the avoidance of the chapatis. So this is the timeline for the history. In the March 2024, there was only fever followed by the pancerebellar symptom. During June episode, fever with pancerebellar symptom with GI symptom. In August, fever with pancerebral symptom, with GI symptom and sensory symptoms.
In between the attacks, whether the patient is absolutely normal or the cerebral
Uh, no, sir, not absolutely normal. But he was able to do his day-to-day activity. He is an auto driver by occupation, and he used to drive in between, sir. But no, fully like a worsening was not there. But fully recovery also was not there, sir.
Vipshiana, the
Yes,
first
sir.
one you said 70 to 80% improvement.
Yes, sir.
The second one in June episode,
Yes,
what
sir.
again steroids treated, what was the degree of improvement?
Sir, improved partially clinical
Which means
improvement
how
was
much?
there,
How
sir.
much? Partial means?
Sir, around this also 60 to 70% improvement was there, sir.
Okay.
TTG was done initially when you
Sorry,
did
sir?
a biopsy and everything. Did you do a TTG?
Sir, I'm coming to the investigation, sir, after discussion. Should I proceed with the
Continue.
investigation now itself?
Continue.
So no history of seizure, LOC hallucination, no bladder involvement, no breathing difficulty, no history of weight loss, decreased appetite, no history of high risk behavior, blood transfusion, skin lesion, head injury, no history of toxin, drug exposure or recent vaccination. Past history is a known case of type 2 DM but on diet control. Known case of cervical spondylosis with a history of heavy weight lifting for past 20 years. MRI cervical spine showing degenerative disc changes. No history of any CAD, CAV or seizure disorder. Personal history, chronic smoker, 4 to 5 BDs per day for past 20 years and stopped since the first episode of the cerebral ataxia. Then ex-alcoholic, 3 to 4 times per week, usually 90 to 80 ml, stopped for past 5 years. Family history of a death of father and paternal uncle with a fever with jaundice in same month, sir. No history of cerebral symptoms in other family members. Coming to the general examination, built normal, conjunctival condition was that no pallor, cyanosis, icterus, BP normal, no postural fall in the BP, all peripheral pulse were felt, no stigmata of TB and HIV, no neurocutaneous marker, no telangiectasia, no KF ring. Coming to the cranial nerve, other cranial nerve was normal except for the saccadic slowing and the nystagmus was there, which is gaze evoked nystagmus. Other cranial nerve is no normal, sir. Tone, all four limb tone was reduced. Power examination, subtle discrepancy in the left and right, sir. Left side power is around 4/5, sir. Right side full power, sir. Other superficial reflex are normal, sir. DTR are depressed 1+ only, sir. Sensory examination, decreased pain, temperature, touch over distal extremity up to the both knees in the lower limb, fingers in upper limb, glow stocking type, sir. Vibration reduced up to the both MTP, sir. With a reduced joint position sense over the toes of the both feet. Rhombox swaying to the either side with open eyes, sir, but on attempt and closure, worsening on the swaying was there, sir. Left more than right. Coming to the cerebral symptom, pancerebral symptom were there, sir. FNT, FFNT was affected. Nystagmus was there. Dysdiacokinesia was there. Heel shin test was positive. Dysarthria, titubation, intentional tremor, and dystometria was present, sir. All the symptoms were left more than right. Pendular knee, rebound phenomena were absent, sir. Limb gait, truncal ataxia, and wide base gait was there, sir. So these are the video.
Okay. Go ahead. Next video is okay.
And walking, so swaying was there, left more than right. And this is wide base gaze, sir. With eye closure, worsening of the ataxia was there, sir. Impaired finger nose test, sir. At the end of the movement, intentional tremor was both side, both symptom left more than right, sir. Finger nose finger test, sir. Sir, nystagmus video, sir. At the end gaze on the left beating, nystagmus was there, sir. This was a speech video, sir. Gait, ataxic stance, wide bait, sir. Stride length variable, step length variable, swaying to the either side, left more than right. Tandem walking, not able to do. Extrapyramidal symptom, no resting tremor, bradykinesia, routing, pouting, snouting absent, palmar grass, plantar grass absent, no strial toe, mask-like face was absent, applause sign negative, no abnormal sweating, no patchy hair loss, no postural fall in BP. Other system, S1, S2 normal, respiratory system clear, organomegaly there was in per abdocer, splenomegaly around moderate splenomegaly and mild hepatomegaly was there, sir. Coming to the summary, 48-year male, right-handed gentleman, known case of cervical spondylosis, presented with fever followed by the tremor, unsteadiness, incoordination of the movement, head nodding affecting day-to-day activity, aggravation of the symptoms with a fever episode. On examination, there were the pancerebellar symptoms, pancerebellar sign, motor weakness on the left side with the sensory involvement in the form of pinprick sensation followed by the numbness over the both lower limb up to the knee with worsening of the unsteadiness on the eye closure with intact cognition, bladder, other cranial nerve without any positive family history. Structure involved, cerebellum, its connection, pancerebellum, peripheral nerve, both small fiber and large fiber, left hemiparesis, right corticospinal tract.
Left hemiparesis, you don't have any evidence. Bilateral plantar flexor.
Yes, sir. Plantar is flexor, sir, but weakness was definitely, sir. Hand grip is around 70% only coming, sir, on the left side.
Is it due to the asymmetrical cerebellar involvement? Is a tone on the left side?
Tone, all four limb tone decreased, sir.
Decreased. So,
yes, sir.
To say there is a pyramidal signs.
Yes, sir.
So it may be due to cerebellar hypotonia, this weakness, we don't know. We don't
Good. No, sir.
Pyramidal sign. Yes, okay. Go
so, coming to the etiology, whether it is we are going for a treatable or versus degenerative. So,
why do you bring in degenerative here?
Sir, multiple time it's coming, sir. Plus cerebellar symptoms are never recovered.
One minute. These are episodic cerebellar involvement. Right?
Yes, sir. But
degenerative, which is a recurrent episodic involvement. Why
in between the patient,
degenerative?
In between patient never recover fully, sir. Yes, ma'am. Yes, ma'am.
60 to 70% improvement is good enough not to consider degenerative.
No, sir, we have mainly evaluated the treatable causes only, sir. Treatable causes only we have evaluated. We are clueless, sir. Additional symptoms of peripheral neuropathy, large fiber neuropathy are involved, sir. With the MRI going in for a cerebellar atrophy. So, we have subsequent sites.
Treatable, I entirely agree. Why do you consider degenerative? That's my question. That's all.
So after clinical examination, it should be treated as a episodic. There is a recurrent cerebellar.
Recurrent. And with the improvement of 60 to 70%. Where is the question? And twice he has improved to 60 to 70%. Then where does degeneration come in?
Sir, degeneration, we never thought of degeneration, sir. Till now, we are evaluated for treatable causes only, sir.
Correct, ma. Etiology la adu vendandra. Treatable.
Okay, sir. Fine, sir. Fine. Agreed.
Differential diagnosis of treatable causes podunga.
Yeah,
okay,
sir.
Sir. Okay, sir. Okay, sir.
No, but diagnosis is obvious, right? Why degeneration?
See, Chittambalam already has the diagnosis.
No other DD, sir. From the presentation, diagnosis only celiac disease. No, nothing else. Diagnosis only celiac disease from the presentation they have given. There is no big DD, sir. All the features are fitting in with the celiac disease only, sir.
Mitochondrial irukka mudiyadha?
Sir, age and so much of
age, no fertility, no family history for mitochondrial, sir.
Mitochondrial neurogastrointestinal encephalopathy, GIE. Neurogastrointestinal encephalopathy. ரெண்டு தான் அங்க இருக்கு. ஒன்னு cerebellar features, அடுத்தது gastrointestinal, peripheral nerve. எல்லாமே fits in with MNGI.
இல்ல சார் fever வேற வருது சார். Inflammatory features.
Fever mitochondrial வராதா?
இல்ல சார்.
Sorry, anyway, let's see. Sir.
Hello.
Should I proceed, sir?
Yes, 1 minute.
Yes, sir.
His father and his relative also died of fever and jaundice. Am I right?
Yes, sir. In the same month, sir. Not means both were admitted within 20 days. They both expired in different hospitals, sir. And same etiology.
Mediterranean fever with demyelination or inflammatory of the cerebellum, CNS involvement. Like
Justin,
yes, sir.
Okay.
For our patient, no jaundice was there, sir. But
both we have a jaundice fever with the CNS manifestation, like CNS vascularity. There are syndromes with the familial Mediterranean fever. Fever only triggered the tear event.
Yes, sir. So that's the first
Rare
diagnosis. We
possibility.
thought of very post-infectious cerebralitis with some as the history of
Runs in
infective.
families, that's what the family members also affected.
Sir, Ramakrishnan, sir.
Yes, Ram.
Sir, in my presentation, generally metabolic disorder, as you said, mitochondrial is the first possibility we have to keep in mind, sir.
Thank you.
Generally, the fever or any stressful event, even exercise, can precipitate kind of condition, sir. So it is when fever precipitates an event, we always think of a neurometabolic disorder as a possibility, sir.
Apart from mitochondrial, what else, Ram?
Sir, other things are very rare, sir. That will be more common in children, like organic acidurias. When if they say organomegaly, probably Niemann Pick type C, but that will cause to have more progressive symptoms, sir. One is mitochondrial, other is organic aciduria. We have to keep in mind.
Do you agree with the neuro gastrointestinal encephalopathy?
Yes, sir. That is, I agree with that, sir.
It starts from the cerebralitis of post-infectious Whipple's. Everything can possible, sir.
அவங்க போட்டிருக்காங்க அதெல்லாம்.
Yes, sir.
அவங்க போட்டிருக்காங்க.
Actually, this patient is cerebral ataxia with the peripheral nerve problem. That happens mostly in celiac disease, even Whipple's disease. This peripheral neuropathy is not a component. So
again, every time loose stools, presence of loose stools.
Gastrointestinal
patient trying to avoid chapatis.
Ocular வேற இருக்கு சிற்றம்பலம்.
He avoids chapatis also. And these sort of fevers are also known in celiac disease. Celiac disease, like many other inflammatory syndromes, can present like periodic fevers also, sir.
Yes, sir.
Okay.
Let them go
As
ahead.
Ramakrishnan told, this maple syrup urine disease and this another citrullinemia, all these organic acidurias can have a fluctuating cerebral ataxia.
அது ரேர்னு சொல்லிட்டாருப்பா. அது ரேர்னு
சொல்லிட்டாரு. Whether it's an infective fever triggering a neurological syndrome or the fever itself is part of the basic disease is the question. If the fever becomes a part of the presenting disease, then it is celiac disease becomes likely and degenerative disorder like mitochondrial go away, sir.
Right. Proceed பண்ணட்டும்.
Okay, sir. With all the previous history, we thought of peripheral nerve plus pyramidal tract in the background history of the pancerebellar syndrome. So if we everything together as treatable, post-infectious cerebralitis, paraneoplastic autoimmune Whipple's, gluten-sensitive ataxia, Wilson disease with NRDD, and rarely.
Paraneoplastic, no need to bring here because it is fluctuating, improving, fast progressing, and not responsive. No.
Point taken.
Yes. Okay.
Okay, sir. Thank you, sir. So coming to the investigation, routine CBC, LFT, RFT were normal. Virology, HIV, VDRL, HCV, HBsAg was negative. CRP was positive. ESR, ASO was negative. Dengue, lepto, scrub typhus, vidal, malaria parasite was negative. Urine blood culture, no growth. Chest X-ray normal. USG A+K shows fatty grade liver. USG scrotum normal. ANA for the patient was negative. CSF analysis, CSF protein was showing 48. CSF culture negative, vitamin B12 level 450 normal, stool routine microscopy normal, genetic analysis sent and report is awaited. As the patient was giving doubtful.
Any specific genetic analysis or just exome sequencing?
Exome sequence, sir.
Okay.
As patient was giving doubtful history of avoidance of chapati, we proceed for the repeat duodenal biopsy. One biopsy we did in 2024, which was showing chronic duodenitis. And this year also we repeated the duodenal biopsy, which showed mild duodenitis with no villi changes or inflammation. We sent for the pass to rule out Whipple disease. It was negative. At the background of the gluten-sensitive ataxia, we proceed for the anti-TTG antibody and the IgA endomysial antibody. Both were negative.
The anti-TTG was IgG or IgA? Both.
போடுங்க அப்படி.
G.
IgG கேக்குறாரு.
IgG தான் sir.
Sorry sir, audible sir. IgG sir, anti-TTG IgG done sir.
This is for Hashimoto's. You want Hashimoto's?
Sir, usually patients may have IgA deficiency, sir, but still IgG is sufficient, sir. That is what from the gastroenterologist side they are telling, sir.
Okay,
Both IgA as well as IgG should be worked out, since because many will have a coexisting IgA deficiency. But still, we can go in for IgG alone, sir.
Right, go ahead.
CT chest for the chronic fever, we work up for the fever. CT chest was normal. CT abdomen was showing mild hepatomegaly with borderline splenomegaly. As paraneoplastic was one of the DD, so we sent the workup to the NIMHANS, and all the antibodies PUR, RE, YO, and JD65 also was negative, and MPFICin is negative.
Because of organomegaly and cerebral ataxia, did you rule out a Niemann-Pick disease in this patient? Niemann-Pick.
Yes, sir, but age of onset is around 45 years age, sir. No cognitive delay in the patient. No developmental delay also was not there. No seizure history. No jaundice.
And yes, vertical gaze palsy, all these things.
No gaze paresis. Vertical gaze paresis was not there, sir.
Okay, good.
Paraneoplastic workup negative, sir. NCS all four limb normal study. MRI brain March 2024 is reported as a right vertebral artery mildly hypoplastic, rest normal. MRI C spine was showing degenerative. This is at the cervical and lumbar region with loss of cervical lordosis. C5, C6.
One small question.
Yes, sir.
Consider this episodic ataxia in this patient. Episodic ataxia, which is exacerbated.
Sir, age of the onset is not in the first decade, sir. Is almost 48-year male, sir. No other seizure history, sir. Plus, in between, his fully symptoms were not recover completely throughout the 1 year. In episodic type 2 also, it can present as a persistent symptoms, where other symptoms like vertical gaze palsy, seizure, all are going against it. Plus peripheral neuropathy, and not improving with the patient has a drastic response to the steroids, sir. So
Yes.
thought of less likely.
Type 1, type 2 usually starts in the childhood.
Childhood, sir.
Early type 2 can start. Early type 2 can start in the adult, and you can have a persistent cerebral ataxia. They will have exacerbated by the systemic illness and all.
Yes,
but
sir.
I think the peripheral neuropathy component will not be there in episode.
Yes, sir.
Okay. Yes.
Echo was, so these are the March 2024 MRI, sir. They reported as a normal, sir, but here was a cerebral folio was prominent, sir. For this age, we discussed the patient, this MRI with radiologist also, sir. So at the age of 48, they told this look less likely to be, they won't report as atrophy, but foveal prominence is there, sir. Then this is a repeat MRI.
Vermian atrophy is there.
Vermian atrophy, but they have not reported officially, sir, but orally they told it. Like,
even this sagittal section also you can see.
Sagittal section also, supravermial region anterior lobe atrophy is there, sir.
Prominent folio of the vermis in the second. Yes, here.
Yes, here.
Okay.
So this is the repeat MRI in 2025. Again, the same finding. Cerebral fovea prominence is there and the atrophy is there, but they are reported as a normal, sir. This is the MRI C spine is showing the cervical disc disease. So coming to the discussion, sir.
1 minute, can I speak, sir?
Please.
Sir, earlier you were inquiring about why degeneration has been put in the slide, no, sir.
Yeah,
Actually, we have evaluated completely for all the treatable causes, sir. Though our first diagnosis was celiac disease, gluten-sensitive ataxia, none of the investigations were giving concrete evidence for gluten-sensitive ataxia, sir. So, on the background of an imaging which is going in for an atrophy, we could think of degenerative. I thought not degenerative, but should be kept in mind, sir, because all the causes have been ruled out. Still, we are clueless.
What degenerative disorder, ma?
Actually, SCS6, sir, spinocerebral ataxia 6 can have a fluctuating cerebral ataxia in the beginning.
Yes, sir.
Later,
Yes, sir.
go for
Gastro, do they also have an associated gastrointestinal symptoms?
that is
So
actually
that's doubtful chapati intolerance,
Chapati
sir.
outnuma, chapati outnuma.
Sir,
Apart from
definitely
chapati.
gastrointestinal symptoms, sir. One another thing is that 60% of patients may have literature, but can have cerebral atrophy, vermian atrophy in immune mediated ataxias. Gluten lay cerebral atrophy varlam, sir. Adha kuda eduthukalam.
Correct, ma. Adana illiye. See,
sir. So, sir, you have to give the diagnosis, sir. I don't know, sir.
I am saying it's a mitochondrial neurogastrointestinal enteropathy.
Yes, sir, actually, age of onset is little earlier, sir. Then another thing is ophthalmoparesis, ophthalmological findings in MNG.
Ophthalmic finding irukku
sir, more of ptosis and ophthalmoparesis.
Whatever it is, that's an ophthalmoparesis and nystagmus also is. Amma ellam classical ah varnom avasiyam illa.
Okay, sir.
Irukka vendiyadella irukkudu. peripheral neuropathy.
Mitochondrial நீங்க CSF lactate pyruvate and muscle biopsy anything you have done?
No, sir. Muscle biopsy not done, sir.
Okay, sir.
Jawahar sir, this patient has got pan-cerebellar ataxia with fever, GI tract symptoms, 3 episodes, very good response to steroid. The MRI showing, but I'm not convinced about the atrophy, but if at all, if it is a very mild atrophy, so with this, all this finding, I will think in terms of immune-mediated process rather than the metabolic or structural causes. Even though the SLE can cause reversible cerebellar dysfunction with lot of antibodies, that can,
Yes, sir.
we can also have cerebellar atrophy. So Kalpana
Yes,
has
sir.
done a lot of investigations, antibodies, but still we are not able to find out the cause. So we think of other causes like GFAP astrocytopathy, where they can have acute attacks of cerebral ataxia response to steroids. But here the
GPF,
is also involved. That is encephalitis.
GFAP.
The anti-DPP also, where you can have recurrent episodes of encephalitis, cerebellar symptoms. But we are
Alagation
not
தானே?
able to antibodies.
Alagation தானே பேசுறது?
ஆமா சார்.
சரி, gastrointestinal symptoms ஒமிட் பண்ண முடியாது, பெரிஃபரல் நியூரோபதியை ஒமிட் பண்ண முடியாது. அதெல்லாமா இன்க்ளூட் பண்ணணும்ல?
So
Again,
it could be, sir, it could be either celiac or mitochondrial. We have to both out of these two, one should exist.
Out of which two? Jawahar, which two?
Sir, the celiac and mitochondrial. Celiac
Celiac
disease
தான்
and
அவங்க
mitochondrial.
2 தடவை biopsy பண்ணி வில்லை நார்மல்ன்றாங்களே.
இல்ல சார், இதுல என்ன சொல்றாங்க, the celiac disease sometimes your duodenal by the villus biopsy may be normal also.
அப்புறம் எப்படி தான் எஸ்டாப்லிஷ் பண்ணுவ?
But antibody is negative.
Antibody is
காமிச்சிட்டாங்க, ஆன்டிபாடியும் தான் காமிச்சிட்டாங்க.
So then how do you explain the steroid response in all the 3 episodes can occur in mitochondrial encephalopathies?
I don't know.
Mitochondrial encephalopathy also can be fluctuating
Sir,
cause.
can I come in?
Doesn't respond to steroid.
You
Yeah.
are most welcome, Vijayan. சொல்லுங்க.
The closest thing is mitochondrial only, and that can be responsive to immunotherapy, including steroids. The only way to
I am
establish
not so sure, Vijayan. I am not so sure whether they respond. Ram,
they do
MNJ
respond, sir. Mitochondrial encephalopathies do respond to
encephalopathy,
immunotherapy,
yes.
including
ராமகிருஷ்ணன் கேட்பான். ராமகிருஷ்ணன்,
including steroids, and maybe the
வந்து ஸ்டீராய்டு ரெஸ்பான்சிவா?
இல்லைங்க சார், எனக்கு தெரிஞ்ச வரைக்கும் இல்லைங்க சார். மறுபடியும் படிச்சு பார்க்கணும்.
no, definitely mitochondrial, there is evidence that definitely
எந்த
mitochondrial
மைட்டோகாண்ட்ரியல்?
encephalopathies.
அம்மா விஜயன், எந்த மைட்டோகாண்ட்ரியல் பிரசன்டேஷன்?
அது no one can, I can't tell you the exact diagnosis, but that seems to be the closest diagnosis
அது
here.
கரெக்ட், I agree. That's my
One,
first diagnosis.
and 2, and it can respond to steroids. 2, 3, the only way to establish probably whole exome sequencing, including
தான்
mitochondria.
பண்ணிருக்காங்கன்னு நினைக்கிறேன்.
Yes, sir. Send, sir. அனுப்புறேன் சார்.
சிற்றம்பலம் என்ன சைலண்டா இருக்கீங்க?
சிற்றம்பலம் லாஸ்ட் ஃபைனல் ரவுண்ட் பவுட்டுக்கு வருவார்.
என்ன ஆளு?
இல்ல சார்.
ஆள காணோம். சரி.
Again, I will think about celiac disease with negative biopsy.
அப்படி போடு.
Still, I'm not, yes sir, not going
Zero-
for
zero negative மாதிரி biopsy negative
yes,
celiac
sir,
disease.
celiac disease with negative biopsy, sir.
அதான். biopsy negative celiac disease and antibody negative celiac disease. Biopsy
Sir,
only.
antibody negative celiac disease இருக்கு. There is entity called
ரெண்டும் இருக்குமா? இங்க ரெண்டும் இருக்கு. Antibody negative.
What percentage is negative? It's very
Sir,
less.
Allegation, I was allegation sir's assistant, sir. He was medicine HOD, sir. Do you remember, sir? We presented a young boy presenting with 3 grams anemia now, sir. He was HLA. We did HLA typing, sir. When I was assistant in Tirunelveli Medical College post MD, sir. We presented, sir, one case. We put to us poster. One young boy who presented with anemia alone, sir. We did all the extensive workup and we did HLA typing, sir. With HLA typing, we proved celiac, sir, for him. Sir, remembers, I don't know. Allegation, sir. It was
அம்மா
purely
celiac என்னமா HLA typing prove பண்ணும்?
Sir, DQ2 and DQ8 will be positive, sir. That is in patients who are, that is also part of the workup. If you are very much suspecting a celiac disease, where biopsy is negative and antibodies are negative, you can go for HLA, sir.
சரி, இந்த ஹோல் எக்ஸோம் சீக்வென்சிங் போயிருக்காங்க. வரட்டும் அது. சொல்லுங்கம்மா. கண்டினியூமா.
Yes, sir.
கல்பனா, continue.
So the problem is skip lesions in the small intestine. The biopsy may miss that. This is
Correct,
the same as your this thing, sir, temporal arthritis.
Yeah,
Skip
we'll find
lesions.
all excuses. Yes.
Yes, sir. Yes, sir.
Yes, sir. Good. You are persistent.
Sir, Should I proceed, sir?
Please go ahead.
Etiology of the cerebral ataxia: acute onset, subacute, and chronic. For acute, intoxication, viral cerebralitis, and post-infectious syndrome. Subacute, intoxication, cytotoxic drug, alcoholic, Lyme disease. Chronic, paraneoplastic, antiglidin antibody, hypothyroidism, inherited disease, Tabes dorsalis, and the phenytoin toxicity. So this is the how to proceed for the cerebral ataxia. Suspect ataxia based on the history and examination: sensory neuropathy, Parkinsonism, vestibular, muscle, orthopedic. All patients require MRI brain to rule out any superficial cirrhosis, Creutzfeldt-Jakob, Wernicke's encephalopathy. So in presence of the family history, either AD, AR, mitochondrial, and no family history, it could be a late onset ataxia.
One minute.
Yes.
There is
Yes, sir.
another differential diagnosis.
Yes, sir.
Sensory ataxia with neuropathy, dysarthria, and ophthalmology. Sando.
Sando, sir.
Sando,
no.
unlikely,
Yes,
but
sir.
you have to consider that also.
Yes, sir. Sando also wasn't. It is also for because of the mitochondrial dysfunction for Paul gene mutations. The mitochondrial, sir. Point against is no blindness history, no micronus.
ஒரே நிமிஷம்.
Yes, sir. Yes, sir.
Which is Paul G mutation?
That Sando was having Paul G ataxia.
Sando is Paul G.
Yes, sir. Mitochondrial only. Point against is no myoclonus, sir, and no blindness history for Paul G.
MNGA-லயும் Paul G இருக்குமா mutation?
Yes, sir.
Oh.
Sir, mitochondrial you're saying no, sir, Sando?
ஆமா இல்ல mitochondrial neurogastrointestinal encephalopathy-லயும் அதுவும் Paul G mutation-ஆன்னு கேக்குறேன்.
Yes, sir. One of the was given sir Sando with Paul G ataxia. Okay, sir.
Thank you.
No family history, we can think of late onset ataxia. So these are the DDs for the autoimmune treatable ataxia. For our patient, we thought of gluten, but decade is 5th to 6th decade. Majority have no GI symptom. Test for the anti-gluten antibody will be present, and the treatment will be the gluten-free diet and treatment for the hypovitaminosis. Other autoimmune causes like Hashimoto, TSH was normal, GAD antibody was negative, paraneoplastic workup was negative. For SLE, ANA was negative. For Sjogren, Behcet, and neurosarcoidosis, we didn't thought of, sir. So this is the brain intestine axis, sir, for the gluten sensitivity, gastrointestinal symptoms, and the neurological presentation. So celiac disease, non-celiac gluten sensitivity, and wheat allergy. The neurological symptom include the ataxia, peripheral neuropathy, epilepsy, migraine, myopathy, cognitive deterioration, and neuropsychiatric symptoms. So these are the few articles regarding the cerebral degeneration in the gluten ataxia, and which links to the microglial activation, sir. And this is the one more patient with the progressive cerebral ataxia and myoclonus, which showing the MRI brain was showing atrophy, sir. Nearly 60% of the patient can show the atrophy in the gluten sensitivity, sir. So these are the other causes for the episodic and intermittent cerebral ataxia, which include the mitochondrial, autoimmune, and vascular and other CV junction causes, sir. For degenerative, SCA3 we thought of as SCA2, SCA18, and SCA46. SCA2 with predominant neuropathy, ophthalmoparesis, and extrapyramidal features, sir. SCA18 for the sensory motor neuropathy, and SCA46 for the sensory neuropathy, sir. Last we thought of idiopathic.
SCA6 சொன்னாரே அது.
SCA6 also, sir. But it will be only pure cerebellar symptoms as SCA6 without any sensory or pyramidal.
SCA6 tremor இருக்குமாமா?
Pure cerebellar.
12 tremor இருக்கும், 6லயும் tremor இருக்குமா?
Pure cerebellum all will be there, but sir, other peripheral neuropathy feature and sensory and pyramidal won't be there in SCA6.
Continue.
The fluctuating course of cerebellar ataxia exaggerated by the systemic illness in a degenerative spinocerebellar ataxia can happen in spinal ataxia 12,
yes, sir.
40, 12, 27, 40 to 42.
Yes, sir.
All this.
என்னன்னா
6, 12, 27, 42.
tremor இருக்கும். அடுத்தது
இதெல்லாமே வந்து HCA இல்ல சார், fluctuating course was exaggerated by the systemic illness like diarrhea.
Yes, sir.
42
6, 12, 27, 42.
Oh, okay. Continue, ma. Presenter, continue.
Last is we thought of idiopathic late onset cerebral ataxia. With patient has cerebral ataxia as a core feature, and scanning speech will be common. Ocular finding will be include saccadic pursuit, saccadic hypometria, or gaze evoke nystagmus, impair OKN. In addition, patient may have signs of pyramidal involvement such as hyper or hyporeflexia, positive Babinski sign, spasticity. With the image findings of the patient with loci include in isolated cerebral atrophy or possibly concomitant brainstem or the spinal cord atrophy. It can be caused by the combination of the genetic and the environmental factors, sir. The last slide. Thank you, sir.
Thank you very much. I thank the team, entire team, Dr. Kalpana and Kanyakumari Medical College Neurology Department team. Extensively investigated all the 4 cases. Wonderful piece. Yes, sir.
ஆனா எல்லா கேஸ்லயும் நம்ம டயக்னோசிஸே வரல.
So all are complicated cases, sir.
That is
So
important.
it's a feast for.
That's right. That is what neurology is.
Yes.
I think we'll have to hand over all these cases to Chitrambalam.
Actually, they would have presented in Shine program. I don't know why they have not come. Okay.
இல்ல அடுத்ததுல வரலாம், அடுத்ததுல கொண்டு வரலாம். என்ன?
Okay.
Sir, Ramakrishnan patient.
Please go ahead, Ram.
Sir, in the whole exam sequencing will not pick up the differentials what we have considered, sir.
Paul-G mutation வராது அதுல.
இல்ல ஆமாங்க சார், மைட்டோகாண்ட்ரியல் நம்ம தனியா ஜீன் சீக்வென்சிங் பண்ணணும் சார். ஸ்பைனோசெரிபில்லர் அட்டாக்சியா வந்து ட்ரிப்ளெட் எக்ஸ்பான்ஷன் டிசார்டர் சார். அதுல இந்த ஹோல் எக்ஸாம் சீக்வென்சிங்ல வராதுங்க சார்.
சரி, Paul-G-க்கு என்ன பண்ணனும்?
Yes sir, I have informed the genetic analyst over sir. நான் சொல்லிருக்கேன் சார். It don't come in whole exome sequencing, targeted genome sequencing இருக்கு சார். அதுல given the 2 differentials சார். அது ஸ்பெசிஃபிக்கா பார்க்க சொல்லிருக்கோம் சார்.
என்னன்னா
SCAR triplet, new trinucleotide repeat sequence won't be picked up by
Paul-G பார்க்க சொல்லுங்கம்மா.
Okay sir.
Paul-G whole examல வராதுங்க சார். நம்ம மைட்டோகாண்ட்ரியல் ஜீன் சீக்வென்சிங்
MNGI வந்து thymidate TYHR gene sir. Thymidate nucleoside enzyme gene தான் சார். அதுல பார்க்கணும். That WES can pick up sir.
Exomex இருக்கு சார். Exomex ன்னு மெட்ஜினோம்ல இருக்கு. That includes mitochondrial plus whole exomes.
ஆமாங்க சார். Exomax பண்ணுனா whole exome mitochondrial வந்துரும் சார்.
Mitochondrial வந்துரும் சார். Exomax
triplet expansion disorders வராதுங்க சார். அது தனியா
ஆமா சார். அது தனியா
சார். அது தனியா we have told them sir. Triplet sequence தனியா கொடுத்திருக்கு சார். With MNGI வந்து TYMP gene தான் சார். Thymidine phosphorylase.
அது வந்து MLPA பண்ணா பிக்கப் பண்ணிக்கலாம்.
Yes sir.
அது சொல்லிருக்கீங்களாமா? கல்பனா
அதுவும் எல்லா ஸ்காவும் பண்றது இல்ல சார். only few ஸ்கா தான் நம்ம பண்றாங்க.
ஆமா சார். எல்லாம் பண்ணா 1 லட்சம் ரூபாய் ஆயிடும் சார். பண்ண முடியாது.
கல்பனா நீங்க எதுக்கு கொடுத்திருக்கீங்க? இப்ப என்ன பண்ண சொல்லிருக்கீங்க?
சார் நான் வந்து இப்ப ஸ்கா வந்துட்டு கொடுத்திருக்கேன் சார். பட் I have spoken to them and அப்புறம் வந்து I will tell other genes ன்னு சொல்லிருக்கேன் சார். after concluding வேற என்ன அடிஷனலா பார்க்கணும்னு சொல்லிருக்கேன்.
ஸ்பெசிஃபிக்கா Paul-G பார்க்க சொல்லுங்கம்மா.
Okay sir.
We go where the pay likely yield is likely.
Sir, one doubt alone sir. Sir, this last case was an auto driver sir. 2 episodes we have treated with methyl sir. Currently is jobless at home sir. What relief can be given sir?
பாக்கி பேர் என்ன சொல்றாங்க கேட்டுக்கிறேன், நானும் தெரிஞ்சுக்கிறேன்.
Is he worsening? Is he worsening in his driving? What does he say? He loses his confidence.
Earlier last year he was able to drive with the ataxia sir, but this year he is not able to go on for job.
Did we give steroids this time?
No sir.
I haven't started sir. I thought that after this discussion can start on treatment sir.
Why not we put him on steroids? At least our job ஆவது போக முடியும்ல.
Okay sir. Okay sir.
Provided others agree.
Yeah, even with the ataxia, they can definitely drive. They can that we have seen several times. Ataxia while they are walking, they will have ataxia. But once they get into the bike, they will drive well, and they will be out also.
Parkinson money.
Yes sir. Previously 1 year he was for transport also, for small distance also he used to drive by auto sir, because he was having gait ataxia on more on walking. But since last 3 months he is saying that while driving also sometimes auto will go to the left side sir.
Yeah, pending the diagnosis is again, since he had responded, put him on methylpred and see. At
Okay,
least let him use his job.
Okay, sir.
Sir, other inputs வேற எதுவும் இருக்கா? விஜயன் எதுவும் சொல்ல போறாரா?
Justin Ramakrishnan
sir, excellent
Vijayan.
cases, interesting and very pragmatic.
Yes, we have to congratulate Kalpana, and it was a wonderful effort on your side and your PGs. Thank you very much.
Thank you, sir. Thank you, sir.
Congrats, Kalpana.
Keep up the good work.
Thank you, sir.
Thank you, sir.
Amazing work from Kanyakumari.
Yes, keep up the good work and
Thank you,
have
sir.
more presentations in more forums, as Jawahar
Okay,
said.
sir.
Thank you, Dr. Kalpana and team, and we are is a very good scientific feast. Thank you very much.
Thank you,
Thank
sir.
you for
Thank
all
you,
the
Jawahar.
who have participated. Thank you, sir.
Thank
Thank
you,
you.
Jawahar.
for
Thank you,
PGs from
Meghandan.
Kanyakumari.
Thank you, Chitramala.
Thank you,
Thank
sir.
you, Ramakrishnan.
sir.
Thanks all the participants. Justin, thank you all very much for making it very lively.
Sitrambalam also.
Yeah, and
Thank you, sir.
சொல்லிட்டேன் சித்ரமலம் சொல்லிட்டேன் அவர் சொல்லாம
Right, sir. Right.
Thank you, sir.
Thank you, Kalpana, for bringing in
Thank
4
you, sir.
cases.
Thank you. Okay,
You
sir.
did a very good job. You
Thank you,
gave
sir.
more cases, more for discussions, more education. Thank you very much.
Okay, sir.
Keep
Thank
doing
you.
it.
Okay, sir.
Thank you,
Thank you,
Kalpana. Thank you.
Thank you.
Thank
Thank you all. And thank you, Sanfama. Thank you, Ishwaran. Thank you.
Thank you, sir. Thank you, sir.
Thank you. It's your support which keeps this forum going. Thank you.
Yes, sir. Thank you, sir.
Thank you. Can we leave?